Okay, great stuff. Perfect. We should be recording now. Excellent. So just to have a look at the objectives, what we're hoping to cover today, everyone, in a little bit more detail. So the first part of today's session will be to look at smoking in the population. So we're going to kind of really kind of zoom out really in terms of tobacco rates of tobacco use and things like that. We'll have a look at global tobacco use first and what the World Health Organization are doing in terms of tobacco control. We'll then have a look at some of the kind of key UK figures, the latest UK figures, including key demographics. We'll have a look at the UK nations and in which areas that we deliver in Read Wellbeing our stop smoking services, which has the highest or lowest prevalence. We'll also have a look at 25 years of smoking cessation, so a bit of a review of what's happened so far, what's been achieved so far in terms of smoking cessation, and also we'll have a look at the new tobacco and vapes bill that will hopefully be coming into law later this year. We'll also have a look at e-cigarettes in a little bit more detail. We're not going to talk too much about using e-cigarettes and the different types, but we're just going to update everyone on the kind of latest information around safety. We'll have a look at the key kind of messages from OHID and NCSET, and we'll have a look at current use of vapes among adults and young people. We're then going to do a bit of a prescription only medication refresher. So as of kind of the second half of last year, 3 prescription only medications are now available and licensed for use in smoking cessation. I know the picture varies across our services as which ones are available, but we'll go through the full kind of usage, potential side effects, cautions, contraindications, requesting POMs a little bit later on. And then in the second part of today's session, if we've got time, we will aim to do a bit of a kind of group session activity, a chance for you all to kind of get to know each other a little bit, share kind of successes, challenges, and kind of what you're looking forward to in terms of smoking cessation, tobacco dependency over the next year. And then we're going to talk about innovation and professional practice. So we're going to talk about some treatments that are a little bit outside the box. We'll also have a look at potential for kind of development of services moving forwards, and we'll have a few kind of internal wellbeing slides where we'll just have a refresher on clinical incident reporting. We'll have a look at key training as well, and the priorities that I have moving forwards in supporting our services, and of course opportunity for you all to share if there's any support you'd like to see moving forwards on our services. So a fair bit of ground to cover on today's training, but hopefully it'll be interesting. Hopefully it will be informative. Does anyone have any questions before we make a start? No, all good. Okay, let's get going. So just before we go into the kind of main content of today's session, just to kind of highlight the main evidence base that I've used to inform today's session. And when you all receive the slides and hopefully the recording, I'm hoping to send everything by the end of this week. I will make sure there is a full reference list and sources so that you can have a look at where I got the information for this presentation. But just to highlight some key sources, this isn't an exhaustive list. Last December, I was fortunate enough to attend the STRP Smoking Cessation Training and Research Programme update in December last year. So lots of interesting updates coming into this session around smoking service performance, cytosine, and a few other updates as well. Earlier this year, I attended the Smoking Cessation and Health Conference. So lots of interesting contributions around the tobacco and vapes bill. Some innovations moving forwards that we may look into as part of our delivery. So some really interesting things to share from there. Of course, NICE, the NG 209 guideline is the kind of main guideline that we have to base our services and the information that we're delivering to our participants. So of course, that's really important. And of course, NCSET as well, which we all know about. ASH, Action on Smoking and Health, a key body in the world of tobacco control in terms of kind of lobbying for kind of positive change around the world of tobacco and smoking, and of course always providing lots of useful resources, fact sheets and research as well, and particularly around the kind of legislation side of things today and e-cigarettes. We've got some sources including OHID and also Department of Health and Social Care as well. So those are some of the kind of main areas that we're kind of drawing from for this presentation. But of course, I will make sure a full list is sent out later this week. Okay. So just a bit of a call to action, everyone. So this was the kind of opening statement from the Smoking Cessation and Health Conference earlier this year from Andrew Ferber, who's the Regional Director of Public Health in the Northwest. And he said, smoking is still driving back health inequalities. We still know that smoking is one of the leading causes of premature death and health inequalities in the UK. So the work that we do in supporting people to stop smoking is incredibly important. And they also said in 2025, there's an opportunity to help people quit tobacco in a way that we haven't seen in many years. So we have really, I think, in the last 12 months, and I think we'll continue to see this moving forwards, an acceleration in terms of the support that we're able to offer. Of course, these aren't necessarily kind of new treatments, but of course we've had varenicline and Zyban back in the last year or two. Cytosine is a new prescription-only medication that we've been able to request from last year as well, but also lots of different innovations that we'll talk about later in terms of using cut down to quit or cut down to stop more, potentially e-cig cessation, smokeless tobacco as well. So hopefully lots of opportunities, lots of kind of new ways of supporting our participants that we'll be able to get into as the next 12 months progress. But I thought that was a nice way to kind of get us started. The work that we do is so important, and you know, this year, the next 12 months could be a really great one in terms of innovation. Let's kind of really zoom out first in terms of smoking in the population. So we're now going to have a look at the global viewpoint of tobacco dependency. So we've just got this quote from the director of the World Health Organization, Department of Health Promotion. They say good progress has been made in tobacco control in recent years, but there's no time for complacency. So some of the key findings globally. So the latest report that we have for this data is early 2024, but still really important to share this. So globally, there are 1.25 billion adult tobacco users, and that equates to 1 in 5 adults worldwide consuming tobacco, compared to 1 in 3 in 2000. So actually, so it is starting to decrease. 150 countries are successfully reducing tobacco use. There are worldwide 362 million adult users of smokeless tobacco. And interestingly, there are 6 countries that are seeing tobacco use rising. Okay. Would anyone like to hazard a guess? Quite a tricky question. Would anyone like to hazard a guess at any potential countries that you think may have an increase in smoking rates recently? So are there any countries that you would like to guess are currently going against the trend? Oops, sorry. So I'll give you all a few moments to have a think. It's a bit of a kind of punt in terms of these countries, but I'll just give you, you're more than welcome to share perhaps maybe any kind of regions or continents or any kind of areas of the globe where you feel kind of smoking cessation may, or tobacco control may be more challenging perhaps. Again, feel free to take a few moments and share in the chat or share the microphone if you'd like to. So in a few moments, I'll share the answers. So Gemma, interesting. Ukraine, so potentially thinking about kind of Eastern Europe, perhaps. Yadira, kind of you've gone with the Middle East, of course, particularly around smokeless tobacco use, also things like kind of water pipes, shishas, hookahs, of course, really prevalent in those areas. Ruth, you mentioned India. Owen, great, Indonesia, that is one of the countries. And Robin, I think that is quite a nice kind of summary, potentially countries in kind of Southeast Asia, Middle East. Let's uncover the slide, everyone, and see which countries are seeing a rise in tobacco use. So Congo and Egypt, Indonesia, Jordan, Oman, and Republic of Moldova. So interestingly, those are the countries where tobacco use is rising at the moment. But I think most importantly, really great to see that at least 150 countries are successfully reducing their tobacco use. In terms of kind of reduction in tobacco use, so Brazil has seen a 35% reduction since 2010. Netherlands not too far off with about a 30% reduction. In terms of the region, so you're absolutely right, Robin. The region where there's the highest tobacco use is Southeast Asia with 26.5%. So yeah. We can see, looking at the graph here, that quite steadily, tobacco use has declined since the year 2000. Of course, there has been a kind of sustained gender gap. So, of course, for males, the current rate of tobacco use is significantly higher than females. And there is a projection, or a hopeful projection, that these rates will continue to decline. So overall, from about 21.7% prevalency at the minute to around 18% by 2030. So yeah, that's a little bit of information, everyone, in terms of where we're at globally in terms of tobacco use. Just some kind of further information. So in July 2024, so last year, the World Health Organization released their first clinical treatment guideline for tobacco cessation in adults. And the aim of the guideline is to support more than 750 million tobacco users who want to quit all forms of tobacco, including cigarettes, water pipes, smokeless, roll-ups, and heated tobacco. And the guideline focuses on behavioural support, using local care providers, digital support, but also pharmacological support as well. They believe, who say that 60% of current tobacco users wish to quit, which equates to about 750 million. However, 70% lack access to cessation services. So hopefully, since last year, work will be going on to impact those, to support those who are less able to access support. For a little while now, the World Health Organization has been using Empower as a bit of an acronym to describe the approach that they have to tobacco control. So they encourage countries to ensure they have a robust kind of monitoring process to monitor the rates of tobacco over time, protecting people from tobacco smoke. So that's all to do with protecting people from secondhand smoke. Of course, offering stop smoking provision, warning about the dangers of tobacco, so talking about kind of education, enforcing tobacco advertising, promotion and sponsorship bans. As with lots of countries, there's always challenges around the lobbying of tobacco companies. So hopefully those will have an impact as well, and raising taxes on tobacco. The UK has one of the highest taxation rates on tobacco out of certainly in Europe, and certainly we know that started to make a difference here, or contributed to our figures as well. So that's just a little bit of information, everyone, on the kind of global viewpoint from the World Health Organization. Any questions there before we focus in on the UK? Good. Okay, so UK figures. So the kind of headliner, really, everyone, is there are approximately 6 million adult smokers in the UK, which equates to a 11.9% smoking rate in the UK. The lowest and yeah, this is the lowest proportion of current smokers since records started. So yeah, still a lot of work to do in terms of reducing the prevalency of smoking. We'll have a look at some of the kind of legislation and some of the guidance that hopefully will support that moving forwards. But definitely, good progress made so far. We did see, so just kind of taking a look at the graph, sort of between kind of 2019, 2020, 2021, the reduction of smoking prevalency kind of slowed a little bit. It didn't plateau, it still decreased, but it did kind of reduce a little bit. However, in the kind of latest data from 22 to 23, we have seen a sharper decline in smoking. So really positive. Hopefully that momentum continues moving forwards. There has, however, been a slight increase in the proportion of hand-rolled cigarettes being used compared to ready-made cigarettes. Potentially, that's due to the highest prevalency of smoking coming from lower income groups, potentially. But yeah, that's an interesting change in the last few years. Just to put all of this in context, everyone. So the highest smoking rates for men were recorded in 1948, and they were 82% for men at that time. For women, the highest smoking rates were recorded in the mid 60s, and they were 45%. So certainly, if we go way before the graph that we've got on the left, certainly we can see the progress that has been made over time. And interestingly, for those who still smoke, the average number of cigarettes smoked has reduced as well. So whereas let's have a look, in 1974, for male, it was 18.4 cigarettes a day. For female, it was 13.7 cigarettes a day. The latest figures for 2023, the average number of cigarettes smoked for male is 11.7 and 10.9 for female. So again, another interesting trend in terms of reduction in number of cigarettes smoked as well. Okay. So just a bit of a kind of question, everyone. Those who have attended my treating tobacco dependency training recently may already have some kind of pointers on this question, but I thought it would be a really good opportunity to kind of push this out to the whole group. Would anyone like to kind of share in the chat or indeed over the microphone any strategies that you feel have supported this decline in tobacco use in the UK? So thinking about, different interventions, perhaps since 2000, maybe also in the last few years, anything that you're aware of that may have contributed to this decline. So I'll just kind of pause there for a few moments to give you all some chance to have a think. Yeah, so a good range of thoughts coming in so far. I'll kind of highlight a few as they're coming in. So yeah, Ruth, so absolutely swap to stop scheme has definitely contributed to this. So swap to stop, I think, was kind of initially brought in around 2023, I think I'm right in saying. Of course, an initiative alongside behavioural support to swap help people to quit by swapping cigarettes for vapes, and certainly that's been a great initiative. We will touch on that a little bit later. Absolutely, Sophie and a few others kind of talking about the price of smoking. So yeah, price increase and cost of living potentially affecting this. It may be interesting to learn that in 2024, this is according to the Office for National Statistics, the average cost of a 20-pack king size ready-made cigarettes were £15.85. So if someone smokes those cigarettes, 20 a day, over a year, they could be saving around five to six thousand pounds a year, which is a significant increase from, from a few years ago, really, where a pack of cigarettes would cost between sort of 12 and 13 pounds. So that's definitely a motivator to quit for sure. Let's have a look at a few more. We've got some great ones. I'll just pick out a few. So let's have a look. Debbie, yeah, vaping. So of course, vaping has kind of increased really in the last 10 years, and is becoming more prevalent, not necessarily in stop smoking services, but in all kind of support sessions, including people just quitting on their own. Vaping is now the most popular and most effective treatment for stopping smoking. Absolutely. Carol, yeah, increase access to products to help smoking. So of course, if someone attends one of our stop smoking services, they have access to the behavioral support we can offer alongside a range of pharmacotherapy as well. Yeah, Bethany, education, absolutely, kind of more ways in which we're kind of sharing information on the harms of tobacco use, absolutely, and digital, Ruth, yeah. So recently at Re Wellbeing, we developed the My Wellbeing Hub. So I'll talk about that a little bit later around kind of innovation around going digital as well. Angelica, absolutely. NRT is still one of the most popular treatments as well for stopping smoking. Absolutely. Yeah, free to access services, Magda. Yeah, Pam, proactive intervention with behavioral support, kind of tailored intervention as well. And yeah, so some really great thoughts, everyone. We've got a much smaller list that I'm going to uncover now, but I think you've shared some really important points there. So yeah, I've just got some points here around the price increase. So yeah, UK has the highest taxation rate on cigarettes compared to other European countries. At the moment, we've got the kind of prohibited sale to under 18s regarding tobacco products, including via vending machines, a ban on purchasing single cigarettes, and small packs of cigarettes as well. There'll be more on that later. Smoke-free places as well. So the indoor ban, as you mentioned, Magda, and we'll also touch on smoke-free places a little bit later on. Yeah, awareness. So in terms of education, standardized packaging with larger health warnings, and rise in e-cigarette use as a less harmful alternative. So yeah, so some really great thoughts there, everyone. And the good news is that in terms of people who are smoking and who are hoping to quit. Around 60% of current smokers, we think, are currently intending to quit or making a quit attempt within the next kind of 3 to 6 months. So, there are lots of people out there. If we take that kind of 60% out of that 66 million, that's at least, I can't do the math straight away, but, at least kind of 3 to 4 million, people out there who are waiting for that kind of opportunity to access support. So yeah, good news there. Let's kind of break it down a little bit further and have a look at UK demographic information regarding smoking rates. So again, just a bit of a question to you all. Would anyone like to share any potential demographic trends you might be aware of around smoking prevalence in the UK? So we've got from left to right, gender, age, we've got I think occupation or qualification. Then we've got socio-economic status. I'll have to double check my notes actually. Yeah. Would anyone like to share any thoughts on demographic rates, demographic information, or linked to stopping smoking? So in terms of gender, do we think rates for males are higher than females? Does anyone know what the socioeconomic group is that may have the highest rate of smoking, perhaps? Anyone know the age group with the highest smoking prevalency? I'll give you all a few moments to have a think and we'll uncover the answers shortly. Yeah, Ruth, yeah, straight away. So just like um, what we had a look at in terms of the global trends, absolutely, the smoking prevalence is high for men than women. Debbie, yeah, a key group where there's high prevalency is the unemployed or the kind of sick, disabled, and unable to return to work within a year groups. Absolutely. Um, Interesting, Pam. We'll come to age groups in a moment, but certainly kind of lower economic groups, absolutely. And kind of Gemma, you kind of answered that. So it's higher in routine and manual socio-economic groups, absolutely. Higher in those who are homeless, absolutely. Yeah, high smoking rates in routine and manual groups, absolutely. Me chat, absolutely. Um, yeah, there are definitely some kind of geographical trends as well, Carol. So potentially there are going to be specific areas where there's higher prevalence, absolutely. Angela, you mentioned the 24 to 34 age group. So yes, that is the age group, or 24 to 35. Or yeah, that's absolutely the ballpark for sure. Yeah, higher in mental health, absolutely, Gemma. It's still around kind of 25 to 30% prevalence in mental health populations. Yeah, lots of really good thoughts there. Thank you, everyone, for those suggestions. Let's uncover. Oops, let's not go back. Let's go forwards, and let's uncover some of these demographic um, um, differences in terms of smoking prevalence. So, yeah, for gender, you're absolutely right. So, men have a slightly higher prevalence of smoking than compared with women. So, men are on around 14% of the minute, women are on 10%. In terms of age groups, so 25 to 34-year-olds have the highest rate of smoking, around 14% at the moment. And however, 18 to 24-year-olds have seen the largest reduction in recent years, from 25.7% in 2011 to just 9, I say just to 9.8% in 2023. Yeah, occupation. So those with no qualifications, as we might expect, have the highest proportion of current smokers. Interestingly, people with a degree, smoking rate is 6%. People with no qualifications, it's 27%. Regarding socioeconomic status, so yeah, we've had a few thoughts here already. So of those who are unemployed, 20% currently smoke compared to 11% in employment. And in terms of socioeconomic group, in terms of routine and manual, it's 20%, managerial and professional, 8%. I feel like I'm calling out the lottery numbers, but hopefully this is interesting to kind of hear these kind of facts and figures. Interestingly, although routine and manual is 20%, it is the socio-economic group which has the kind of steepest decline in smoking rates recently. In terms of ethnicity, so the percentage of adults who smoke are higher for Black, Asian, and Chinese groups than white ethnic groups. And just finally, in terms of marital status, so those married or in a civil partnership have the lowest proportion of current smokers when compared to cohabiting or single. Okay. So definitely some really interesting demographics there. Of course, we haven't highlighted all the key demographics we could go through. Those are just some of the key ones that I found. Any questions on those before we move on to the next slide? All right. So next one, just a bit of an activity really on this one, just again to think about smoking rates. We'll have a look at the UK nations and see where they're at the moment with smoking rates, who has the highest, who has the lowest. And then we've got the kind of 5/6 areas really in which we deliver stop smoking services, and we'll also have a look at which of the areas in which we deliver has the highest and lowest smoking rate. So first of all, would anyone like to guess in the UK which nation in the UK has the highest smoking rate? Do we think the highest smoking rate would be in England, Northern Ireland, Scotland, or Wales? So Debbie going with Scotland. We'll just give it a few moments in case there are any advances on Scotland. So we've got it's 3-1 to England, I think, at the minute. Or 3-2 England, Scotland. No one's going with Wales or Northern Ireland. Oh, Spencer going for Wales. A few more for Scotland. So 5, 4, 3, 2, 1. I'll uncover the answers. So Scotland, interestingly, has the highest smoking rate everyone, with 13.5%, followed by Northern Ireland with 13.3%. Then Wales, 12.6. Interestingly, England has the lowest stop smoking rate, sorry, with 11.6%. Okay. Regarding the areas, everyone, where we deliver stop smoking services, so we've got Norfolk, Essex, Leeds, Stoke-on-Trent, and then we've got Kensington and Chelsea and Westminster. So those are 2 boroughs actually. So we've got Kensington and Chelsea and Westminster. So in terms of those 6 areas, again, would anyone like to guess where the highest rate of smoking is? Can I just give you a few moments to have a think? Of course, wherever we deliver, we may feel that that's the highest smoking rate because we're aware of the challenges, we're aware of the kind of specifics in terms of who we're supporting. So yeah, we've got we've got quite a few coming through, potentially more coming through for Stoke. We've also got some votes for Norfolk and Kensington, Chelsea and Westminster. Just give it a few moments. This will be really interesting. It's definitely not no competition. Let's have a look. All right, so the area with the highest rate of smoking is Westminster. So in terms of the areas in which we deliver, Westminster has 13.7% smoking rate. That's followed by Stoke-on-Trent. So of course, prior to December, Stoke would be the highest. However, with our colleagues in 1 Kensington and Chelsea and Westminster joining us in December, that now is the highest. Then we've got Essex and Norfolk tied on 12.2%. Leeds has 11.6%. Admittedly, this surprised me a little bit, but I think that's probably because I used to deliver smoking cessation there. This is quite an interesting one. You know, Westminster and Kensington and Chelsea boroughs are next door to each other, but that is quite interesting how Westminster, we've got the 13.7% smoking rate. In Kensington and Chelsea, we've got 10.7%, which is the lowest. So, of course, locally, you may kind of know more than me in terms of those differences and what may lead to these figures. But definitely interesting to know. Okay. So, just a quick one here in terms of cost of smoking cigarettes to society and health. So it's just important to be aware that the overall cost of smoking society in England is currently estimated to be 21.8 billion, including significant costs to the NHS and social care. That has raised. So I think the last reported figure before 21.8 billion a few years ago was 17 billion. So it has actually increased in terms of the cost of smoking to society. And this includes 1.9 billion to the NHS, 1.2 billion to social care costs to local authorities, and 18.3 billion in lost productivity. That's kind of lost hours of work. That's people taking kind of sick leave due to smoking related illnesses, and a few more besides that as well. In terms of health, in terms of health, these aren't kind of super new figures, but in terms of some of the health impacts of smoking. Smoking is still the primary cause of preventable illness and premature death, accounting for approximately 74,600 deaths a year in England in 2019 to 2020. In adults aged 35 and over 500,000 hospital admissions were attributable to smoking, accounting for around 4% of all hospital admissions in this age group. And most smoking related deaths arise from one of three types of disease. It could be lung cancer, COPD, which also incorporates emphysema and bronchitis, and also coronary heart disease. So in 2019, around 15%, 74,600 of all deaths of adults aged 13 and over in England were estimated to be attributable to smoking. So yeah, really important just to kind of highlight. This isn't going to be new information for many of you, but again, really important just to be aware of the impact of smoking, and of course, again, the importance of what we do. Yeah, really interesting to have some thoughts coming through into the chat in terms of insights. So Magda, you mentioned kind of in Westminster, a lot of kind of deprivation, high condensed population living in those small areas too. And yeah, Gemma, you would have thought Chelsea would have had much higher rates of smoking. I suppose Chelsea, you've got those kind of really significant divides in terms of wealthy population, but also people still in kind of deprivation as well. So yeah, really interesting to find out about these trends. Okay. Just a few slides now, everyone, on Stop Smoking Service performance in England. Okay, so we had some recent information regarding Stop Smoking Service performance in England between April to December last year. It was published just a short while ago, so this is quite fresh. So in Stop Smoking Services in England, between April and December last year, there were 162,655 attempts to quit, supported by Stop Smoking Services. Of these, 53.8% successfully quit, and 11.8 quits were carbon monoxide verified. And overall in this time period, 224,000 referrals were made to Stop Smoking Services, and around 72.6% led to a quit attempt start. Okay. We do just have some kind of graphs at the bottom in terms of treatments used. So the three most prevalent treatments used in Stop Smoking Services to support quit attempts were combination nicotine replacement therapy. So that's usually a patch, of course, with an oral NRT product. Then nicotine vapes were the second most prevalent, and then single-use NRT. In terms of other, the kind of 31.5%, so this includes Zyban, although it was quite low levels, also cytosine at quite low levels as well, and also people just attending services to use behavioural support as well. But yeah, interesting to learn that although kind of vapes are the most popular treatment in terms of overall quit attempts, in terms of Stop Smoking Service settings, combination NRT at the moment is the most used pharmacotherapy, but this may change certainly in the next year or so. And yeah, some really interesting figures, everyone, in terms of treatment success rate. Out of those three most prevalent, most used treatments, nicotine vapes was the most effective treatment, just under 60% efficacy. Then we have a bit of an anomaly, and you may like to share some kind of thoughts in terms of why this might be. Single-use NRT showed slightly higher efficacy than compared to combination NRT, which is a little bit of anomaly. You may have some kind of thoughts there in terms of maybe we're offering single-use NRT more to people who are less dependent on nicotine. Therefore, is it perhaps kind of more likely that they're going to quit compared to someone who tries combination NRT for the first time and they're heavily dependent. So there are quite a few points there definitely that we can draw on there. I can see there is a hand up, Pam. I can see a hand up. Feel free to go ahead if you had a question. Yeah.
Yeah, I'm wondering what length of time these figures are taken over. So are they 4-week quits, 12-week quits, a year?
Quit dates achieved. So quits achieved. So not 4-week quits. Literally just quits achieved. Yeah.
Okay, thank you.
Yeah. Cool. So yeah, but yeah, really interesting. Of course, the advice is still that combination NRT is still the kind of gold standard for NRT. That's still in the guidance. This was first kind of brought to my attention at the SCTRP update in December, and the kind of main researcher on that course was also quite surprised about this. But I think definitely, looking into who we might be giving as single-use NRT to compared to combination NRT may kind of lead to a bit of an answer there. Oops. Gone one too far. Yeah, just some additional information. So stop smoking services are, helping to reduce health inequalities. So in that time period between April to December 2024, 53% of people setting a quit date were eligible for free prescriptions. Routine and manual socioeconomic group were the most engaged compared to other socioeconomic groups. And in terms of age group, so this is actually between 2023 2024, interestingly 45 to 59 years were the most engaged age group in that time period. I don't suppose, would anyone like to share why engagement is higher in older age groups, whereas we know 24 to 25-year-olds is where we see that the high smoking prevalence. So let's have a look. I'll pause in case anyone would like to share any brief thoughts on that, or maybe share over the microphone.
Because by the time they get to that age, they're starting to acquire smoking-related illnesses.
Yeah, absolutely. So I think that's probably one of the key elements, Pam. So yeah, becoming more aware of those health implications, absolutely, and potentially starting to have those conversations, whether it's family members or health professionals, around the impact of smoking on their health, absolutely. Looking forward as well, the impact of smoking for sure. So yeah, I think that's general trend of some of the thoughts that we're getting in the chat. So yeah, potentially more smoking related illness, health implications, yet more concerned about health, just that kind of awareness really. So yeah, I think that's absolutely right. Just finally, in terms of stop smoking performance, so these figures are the last figures that we've got for a whole kind of 12 months, so between 2023 and 2024. So it may be interesting to learn in terms of quit date set and throughput over a period of time. So kind of let's say in terms of the early 2010s to 2020, we have seen a bit of a decline in throughput and also quit date set. However, kind of some good news perhaps in terms of stop smoking services, the gaps between quit date set and successful quitters has narrowed after that time. So potentially we are becoming more effective in supporting those who access our services. And in terms of service throughput, it did drop. However, following COVID and lockdowns and things like that, we have seen a slight uptick in service users between in 2023 2024. So hopefully that's a bit of a trend that will continue. And I know that in all of our contracts there's a lot of kind of outreach engagement work to engage as many people as possible onto our programs, and that of course is contributing to some really positive referrals I know that we're getting in our services. So yeah, Interestingly, between 2023 2024, nearly 200,000 people accessed support. In terms of the service setting where people are getting support, so services such as ours that we deliver provided 63% of support to people wanting to quit, which is up from 39% in 19 and 20. So potentially kind of support is moving away from kind of primary care, moving towards stop smoking services, specialist stop smoking services. And interestingly, group interventions are more effective than one-to-one or phone support. So it's important to say that phone support, telephone support hasn't really impacted quit rates in a negative way. Of course, we're still using self-reported quits, and that's absolutely fine. But interestingly, group interventions were found to be slightly more effective than one-to-ones in that time period, potentially due to peer support offered, kind of extra accountability as well within group sessions. And those who may deliver groups on this call today may have some insight there as well. But we'll also have a look at some innovation that we're thinking about around groups later in the session. Okay. All right. So we are, of course, now in 2025, everyone, which marks 25 years of stop smoking services. So stop smoking services were established across England in the year 2000 to 2001. And of course, the aim of our services is to improve quit rates and reduce the number of people who start smoking. Okay, so just some of the headliners, really. So it's estimated that 140,000 lives have been saved so far by smoking cessation, stop smoking service interventions. 10 million quit attempts have been supported by English stop smoking services, and 5 million 4-week quits have been achieved as well. So really significant figures that, absolutely we can, really celebrate and recognise our role in that as well. Quite helpful timing. So Nick, our divisional director for Re-Wellbeing, published on the Together Hub just some information about our stop smoking services in the last few years. So Re-Wellbeing, we started delivering smoking cessation in 2016, which started off with 1U Haringey integrated health service, then kind of 1U 1U Leeds and kind of Cheshire East and things like that, and services like that. And since we've started, we've supported out of the service users who access our services, 64% have successfully quit. So we do have at Re-Wellbeing higher quit rates than the national average. So we can certainly also be proud of the specific work that we've done in Re-Wellbeing, and you're continuing to do as well. In terms of some key findings, so at the peak of throughput, stop smoking services supported 800,000 quit attempts in 2011-2012, which at the time accounted for 10% of smokers. In 2023-2024, stop smoking services supported just shy of 200,000 quit attempts, which at that time accounted for 3.3% of smokers. We are, however, seeing that change in terms of what support people are accessing for smoking cessation. So even though the figures have dropped, the proportion that we're seeing is much higher than it used to be, and is reducing in GPs. So people are moving to our services for support. And 40% of smokers were supported by their GP in 2011-2012. Now it's just 13%. And as I mentioned previously, the shift to telephone support hasn't impacted quit rates. Of course, on some of our services, there are, commissioner requirements where they are encouraging that return back to carbon monoxide verification of quit rates. However, in terms of NCSET and NICE guidance, the way that we are self-reporting is still absolutely accepted at the moment. But it would be great to see more carbon monoxide validated quits moving forwards. So where next with stop smoking services? So some of you may be aware of the NHS long-term plan, which was a 10-year plan to reduce the impact of on secondary care in health settings such as the NHS. So, you know, we are seeing more working together with stop smoking services, and I know in Leeds you work with kind of lung clinics to support those inpatients. I know on some of our other services we have direct links to kind of mental health services as well. So kind of maximizing working together, supporting kind of the continuation of support from inpatients to help them to stop smoking. Lots of different initiatives along those lines that are helping. Of course, there's an increase in digital tools and offers. We'll talk about our My Wellbeing Hub a little bit later on. More targeted work with priority populations. So in Norfolk, you're specifically targeted, aren't you, to focus on the core 20+5 populations, which account for the kind of top 20% most deprived in those areas. Some key kind of geographical kind of population groups as well, and also the 5 key kind of clinical measures of health inequality as well. So our services are becoming more specialized in that way. And also in terms of the way that we deliver our services. So of course, for most of our services as we speak right now, we do have that abrupt quit model and 4-week quit model. However, moving forwards, we definitely see that potentially kind of changing or modifying, where still we see kind of that abrupt quit approach being the most effective way to quit. However, recognizing that some populations will benefit from cutting down first, or may benefit from, you know, preloading of treatment, so that there may be some kind of innovation there in the future. But hopefully that's just a bit of a summary, nice summary there in terms of 25 years of stop smoking services. Any questions on that slide, anyone? Okay. So now we're going to move on to some legislation. So this will be just the kind of final topic really before we pause for our first break for around 15 minutes. So the Tobacco and Vapes Bill. So last year, the government introduced the Tobacco and Vapes Bill in November, a proposed update to the existing tobacco control strategy. The last tobacco control strategy put into law was back in 2017. There's been lots of kind of suggestions, lots of other kind of initiatives that have been put into place in the interim. However, this is the first kind of proper bill that we've had for tobacco control in a number of years. So again, just a quick question to you all. Let's uncover the question. Would anyone like to share in the chat what you think is included in this new bill? So is anyone aware of any changes to tobacco legislation, any changes to tobacco control policy that we may be seeing in the next few months? So Magda, yeah, absolutely. So we've got the age ban, so the commitment to create a smoke-free generation. So for those who I think turn 18 on the 1st of January 2027, they will never reach legal age to purchase tobacco. So generations behind that again will never be able to legally buy purchase tobacco. Yes, Carol, removing disposable vapes. So yeah, that's interestingly a DEFRA, Department of Environment, Food and Rural Affairs initiative, but that's coming very soon, isn't it? The 1st of June, I think that is. So we will talk about that in a moment. Yeah, Gemma, yeah, restrictions in advertising in vapes. So yeah, there are going to be some really key restrictions there. And Spencer, you're absolutely right. The fixed penalty notice for underage sales of vapes, nicotine products, tobacco will increase from £100 to £200. Debbie, absolutely. So an extension to smoke-free restrictions. So currently we've got restrictions around kind of public transport, kind of most public spaces and things like that. But there's going to be a kind of wider approach to hospitals, schools, and other places like that. Yeah, absolutely right, Gemma, and Ruth, absolutely, and with the public spaces. And yeah, Gemma, increase on vapes in pricing. So yeah, absolutely. Even though we know kind of vapes is a effective stop smoking aid, there is going to be new duty on vapes moving forward. So yeah, some really great thoughts, everyone. Oh, sorry, I've gone back again. Sorry. There we go. So yeah, the Tobacco and Vapes Bill is landmark legislation with cross-party support, and the government says it's a world-leading ambition to create a smoke-free generation, and essentially, in 15 years, smoking among 14 to 30-year-olds, the hope is that it will be effectively zero. So that's one of the main aims. There are kind of four key objectives with the tobacco and vapes bills. So to discourage people who do not consume tobacco from starting, particularly young children and young people, support people who already consume tobacco to quit through promoting evidence-based quit aids. Discouraging the uptake of vaping by children and young people, and overseeing safe and effective regulation enforcement systems for tobacco-containing products and vapes as well. Okay, so as you've said, everyone, you've all, I think, discussed pretty much all of these points. So in terms of smoke-free generation, it will be illegal to sell tobacco products to anyone born on or after January the 1st, 2009. So as I mentioned, that will come into action 2027. So for those that were born on January the 1st, 2009, and thereafter, they will never be able to legally purchase tobacco. In terms of extending smoke-free places, so yeah, there's a proposed extension to schools, hospitals to reduce passive smoking exposure, especially for children and vulnerable people. This is probably one of the areas that's being kind of bounced around the most. That there was a proposal to ban smoking in, I think, drinking in pub gardens. However, that's been withdrawn, I think, recently. So that's probably one of the areas that is still being bounced around. In terms of youth vaping, yeah. As Gemma mentioned, targeting the branding, promotion, and advertising of vaping products to children. Yeah, proposals for a tax on e-liquids. So yeah, essentially in terms of advertising of vapes, you'll only be able to see advertising on either point of purchase or specific kind of advertising boards in the community. In terms of enforcement activity, as Spencer mentioned, so there'll be a provision for a licensing scheme for the retail of tobacco and vaping products to tackle potential illicit business and protect legitimate retailers. So a new £200 fixed penalty notice for underage sales. Yeah. £200 fixed penalty, as we mentioned, and yeah, proposed ban on single-use vapes from June the 1st, 2025, and a new registration scheme. So for tobacco, vapes, and nicotine products on the new market. So there'll be work more closely with the MHRA to provide notifications on legitimate nicotine-containing products, tobacco-containing products, and vapes moving forward. So those are some of the key headliners, what's being proposed in the new bill. Where is the bill at the moment? So earlier this year, the bill passed third reading in the House of Commons. It's now currently being bounced around the House of Lords, various different amendments, and it's hoped, there isn't a confirmed date for this. It's hoped that this will pass into law later this year. So that's the hope really for this bill. Some of you may be aware of something called the Stopping the Start policy. So in the previous government, they did propose this Stopping the Start policy, a new tobacco and vapes bill that has, of course, been taken over by what we've just discussed. However, in terms of what they propose and some of the changes, so the new elements of the bill include those extensions on smoke-free places, strengthen regulation on vapes and nicotine products, introduction of the retail licensing scheme for the sale of tobacco, vapes and nicotine products, extension of the current ban on tobacco vending machines to vapes and nicotine products, and the fixed penalty notice as well. So that's what's changed since the stopping the start policy. Okay. So alongside the bill, there are a package of measures to help current smokers to quit, tackle youth vaping, and strengthen enforcement. Is anyone aware of any other measures that have been put in place recently to help people stop smoking and manage youth vaping? We've already mentioned one or two in the chat before. I won't kind of say any answers in case anyone would like to share those again. But is anyone else aware of any other measures, initiatives tackling tobacco and vape use? Okie dokie. Yeah, absolutely right. So we've got some thoughts coming through. Thank you, Gemma. So you mentioned increase on vapes, vape pricing. Absolutely. Yeah, Christiana, absolutely. Disposable vapes ban. Gemma, yeah, limitation of flavors. So that will come into that kind of regulation on vapes. Absolutely. Yeah. Yeah, so some really good points there, everyone. Let's have a look at some of these in a moment. So yeah, over 18. So that's a really good one, youth. I think it was 2007, was it, that the age of sale of tobacco was increased from 16 to 18. So yeah, absolutely, really important to recognise that. So just some additional measures to mention. So the Department of Health and Social Care have provided additional funding for high impact, cost effective stop smoking services. I think we'll uncover some information on the funding in a moment. The National Smoke-Free Pregnancy Incentive Scheme and Swap to Stop. So these are incentives for pregnant smokers to engage in stop smoking services, and also increasing the availability of vapes to adults who would like to quit smoking using e-cigarettes as well. We'll touch on those shortly. Yeah, NHS England expansion of hospital-based tobacco dependency treatment services. So yeah, more focus on inpatient support, particularly in lung clinics and kind of mental health clinics, to support people to stop smoking at place in the hospital, but also ensuring that there's support available for those individuals after they leave hospital to maintain their quits. Yeah, cross-government work to bolster enforcement against illicit tobacco and vapes. So there's been £10 million set aside funding for trading standards in 2025-2026. We may just touch on some kind of potential unintended consequences of the tobacco and vapes bill, maybe kind of illicit tobacco and things like that. So that they're hoping that that's going to come into place to manage those unintended consequences. We've already mentioned the fixed penalty notice, yeah, regulatory measures for tobacco and vapes, and wider system stewardship. So yeah, working more closely with MHRA to support tobacco and vape product notification. Okay, so those are just some additional measures that the government have put in place. In terms of funding, so the current government, this was actually a proposal in the previous government, but the current government has continued it. So in December, they announced 70 million in additional funding for local stop smoking services. In some of our contracts, we have seen some of that funding. So certainly in Stoke, there's kind of wider kind of co-production in terms of support being delivered by kind of ledge centre teams and pharmacy teams, as well as the existing Stoke service. Also kind of more less restrictions in terms of eligibility onto the service as well. So the funding that's been offered through this 70 million is targeted, depending on kind of rates of smoking, cost effectiveness of the support that could be made available with the funding. So there may be other areas that you're aware of in your specific contracts. So yeah, just a few points here on the challenges and opportunities with this bill. So this, of course, is a UK-wide bill, and health is devolved in the UK, which can add complexity. I think we saw that with the COVID lockdowns and the different kind of policies and procedures there. Interestingly, in the House of Lords, so that there could be kind of negatives in terms of lobbying affecting some of the amendments. We might think that they might water down some of the policies. However, there's recently been a new amendment announced for a potential full tobacco ban from 2040. Sorry, it says 2024. It's from 2040. So that's potentially an interesting amendment. Not sure if that would be that would go through, but certainly that would have a lot of impact. Yeah, lobbying. So there's always kind of legal challenges, vested interests with tobacco companies. And of course, getting the balance right on vaping. So we'll talk about disposable vapes ban in a moment, but definitely there needs to be a balance in terms of ensuring that we're making e-cigarettes available for adults who want to stop smoking, but also ensuring that we're tackling youth vaping at the same time. So we'll have a look at that as we move through. So yeah, just a little bit of information on the disposable vapes ban. So this is probably alongside the smoke-free generation, kind of one of the most kind of well-known policies that will be coming into action this year. So interestingly, this wasn't a kind of Department of Health kind of policy. This was actually introduced by DEFRA, so the Department for Environment, Food and Rural Affairs, and this is going to take effect from the 1st of June 2025, and it will be illegal to sell, supply or possess for sale or supply single-use vapes, including non-nicotine versions of single-use vapes. This ban doesn't affect reusable products, so products that can be recharged and refilled with e-liquid or nicotine salts. Only disposables are banned. So yeah, and as long as the vapes can be easily maintained, so replaceable heating coils and things like that, those are still going to be fine and will still be able to be purchased. So why did they announce this disposable vapes ban? So primarily coming from DEFRA, they wanted to use this as a way to protect the environment. So last year, 5 million disposable vapes were littered or discarded every week. Also, they want this to contribute to a reduction in youth vaping. So they found that an introduction in newer versions of single-use vapes, such as Juul, coincided with a rise in youth vaping. It was estimated that around 50 to 60% of youth vaping was attributed to disposable vapes. Ash published some information recently saying that I think that's now reduced to 35%. So that's quite interesting. In anticipation of the disposable vapes ban, youth 11 to 17-year-old use of disposables has significantly decreased. But yeah. Of course, it's important that we know where they're going to. Hopefully it's no nicotine at all, but it's important that we provide that support. And yeah, there's hope that alongside this, the tobacco and vapes bill that we've just discussed will address further youth vaping. So in terms of actions for healthcare and stop smoking services, so yeah, of course, we don't sell vending machines, so with the disposable vapes, we'll move over that one. Yeah, dispose of any leftover stock safely. I'm not aware that we do supply disposable vapes. Usually when we offer vapes, it's the either vape pens or the mod devices, I believe. So that's fine. Of course, service users can continue using disposable vapes if they have legally purchased or been given before the ban. Yeah, this will likely only occur for a short period as people work through their vapes obtained before the ban. So yeah, for anyone that purchased legally disposable vapes, they can still use those products after the ban, as long as they don't sell them. Okay. Actions for those who vape. So the recommendation is to continue to use the rest of their disposable vapes, but then try and move towards reusable versions to support with either stopping their tobacco use or maintaining abstinence. For anyone that does have disposable vapes, they should be promptly recycled. So each local authority does have information on where e-cigarettes can be disposed of. There are usually e-cigarette recycling bins located in kind of community settings. So really important that any remaining disposable vapes are disposed of in a responsible way. And there is a recommendation. I think some vape companies are already doing this, but there's a recommendation that vape retailers offer a take-back service, potentially kind of refund the disposable vapes, but then provide are able to sell those reusable products. So I'm not sure how widely that's being introduced yet, but those are the recommendations for vape shops and vape companies. Does anyone have any questions regarding the disposable vapes ban? We may talk a little bit more on potential impact, unintended consequences, but also positives around this ban when we have a look at e-cigarettes in more detail and have a bit of an update on e-cigs and vapes. But does anyone have any questions so far? No. No, all good. I think we are now at a good point for a break, everyone. So we're at 70 minutes past 10 now. So what I propose we do is break for 13 minutes, if that's okay. Hopefully that's just enough time to pause for refreshment, take your eyes away from the screen. So we'll come back at 10:30, everyone. Do let me know if you've got any questions. I'm going to turn my camera off and microphone off and head away from the screen. But if you've got any questions, do pop in the chat and I'll do my best to answer when we return. So thanks everyone so far. See you all back at 10:30. Thank you. All right, everyone, welcome back. We'll just give it a few moments before we begin. We'll just ensure everyone who's hoping to join us again has a chance to do so before we get started. Great stuff. Welcome back, Magda. Thank you. Great stuff. I think we're all starting to come back now. So I think we will begin the next session, everyone. So the next section, we're first going to focus on e-cigarettes. So we're going to try and go through a nice kind of e-cigarette update. So we're kind of aware of current levels of e-cigarette use, some points around the current standpoints on e-cigarettes and some kind of research. We'll then go through a full update of prescription-only medications now licensed by MHRA for smoking cessation. And then if we've got time before the break, we will just have a bit of a spotlight on pregnancy and smoking, and also supporting routine and manual service users to stop smoking as well. So let's begin, everyone. Okay, so before we have a look at e-cigarettes in further detail, what I thought it would be useful to do is just take us through a bit of a kind of background in terms of the UK perspective on e-cigarettes. So just a bit of a timeline. We probably are missing a few things on this timeline, but just an approximation of key events and key interventions relating to e-cigarettes. So around 2005, 2006, cigarettes started to reach the UK. There is actually information out there suggesting that some of the first e-cigarettes were created in the sort of early 1930s. I think one of the first vapes was patented in 1960s. So e-cigarettes have been around for a while. However, really that they started to reach the UK in the early 2000s, mid 2000s. Around 2007, it suggested that the first e-cigarettes started to become commercially available in the UK. And at the bottom left, we've got the first generation Cigalike models. So these were kind of one of the first models available in the UK, of course, designed to look just like a cigarette. Further generations have kind of improved in terms of the nicotine delivery. And some of these Cigalikes, some of them are rechargeable. Quite a lot of them were single use. And really, most use of first generation devices are those who started using Cigalikes, when they first came in and got used to them, essentially. In 2013, Public Health England commissioned reports, first started to commission reports on e-cigarettes. And in 2015, Public Health England published a review stating that e-cigarettes are around 95% less harmful than smoking. So, that's when that key kind of tagline of e-cigarettes started, around 2015, when, of course, we knew at that time, cigarettes were 95% less harmful than smoking. In 2016, there was an introduction of the first kind of regulations on e-cigarettes, and we'll have a look at the current regulations on e-cigarettes and e-liquids in a moment. Kind of skipping ahead to last year, there was an update to the Cochrane review on e-cigarettes, and they found no serious risks for use for up to 2 years using e-cigarettes, and no real difference between e-cigarettes and NRT in their study. We'll have a look at this in a little bit more detail, that Cochrane review. And e-cigarettes are generally considered now the most popular stop smoking aid, and that there's evidence out there to say that they're probably one of the most effective treatments out there at the moment. Again, I won't go through these models in detail, but of course, what came after the Cigalike model was the second generation vape pens or shisha sticks. Then we've got the mod models. So these are kind of more customizable little bit more kind of powerful as well. And then we've got the kind of most recent version, which are pod mods. So again, these are kind of USB kind of shaped devices coming in a variety of flavors. And pod mods don't just include or aren't just for e-liquids. Or nicotine salts can also be used with those products as well. Okay, so that's just a bit of a kind of very brief overview in terms of where we were and where we are now with e-cigarettes. Let's have a look. So last year, Action on Smoking Health published their latest survey on vaping among adults. And they found that 11% of the adult population currently vape, which includes any use other than just trying it once or twice. So for any use beyond just using it once or twice, they found around 11% currently vape. Interestingly, 39% of smokers currently vape, so concurrently with their smoking habit. Over half of ex-smokers quitting in the past 5 years quit with vapes. And also 53% of vapers are ex-smokers. Okay. So, you know, that we may be able to kind of think of lots of different kind of thoughts or arguments around that. When I kind of heard this at the SCTRP update last year, they were quite encouraged by that, where people are using vapes, whereas perhaps they might have kind of returned back to smoking. So they were quite positive about that. In terms of the kind of types of e-liquid and types of vapes used. 47% of e-cig users use fruit-flavored e-liquid, 16% use tobacco flavor, 53% use refillable versions, and overall in the adult population, 30% use disposables, but that will, you know, potentially go to zero in the next few months. Okay, so we've got just a bit of a graph below those key findings, so we can see the 53% figure at the top of ex-smokers continuing to vape, the 39% currently concurrently vaping and smoking. Interestingly, 8% of never smokers currently vape. There hasn't been a kind of significant increase. It is slightly less than the 2022 figure, but did increase from last year's 6.7%. So, of course, these are the people that we want to kind of address and support to, you know, hopefully ensure that the vaping doesn't lead to smoking. And in a little bit later on in the session, we'll have a look at ways in which we may support those people to stop their use of vaping. Okay. It's important to be aware of the current regulations on e-cigarettes and e-cig liquids. So the minimum age for sale for e-cigarettes is 18 years. The only advertising still allowed is at point of sale, billboards and public transport, so no television adverts and things like that. The maximum strength of e-liquid is 20 milligrams per milliliter. So 20 milligrams of nicotine per milliliter of e-liquid. And the volume of the kind of e-liquid chamber should be no more than 2 milliliters in disposable vapes and no more than 10 milliliters in refillable vapes. The vapes should be child resistant and have tamper evident packaging. Health warnings must cover 30% of the surfaces of the packaging. And through the yellow card reporting system, just like we can report kind of adverse reactions to other nicotine replacement products, other pharmacy-only medications and things like that, any safety concerns or any adverse effects can be reported through the MHRA yellow card reporting system. Where I've had kind of clinical incidents before regarding vaping, usually that's probably the only action that I've asked people to take is to report on the yellow cards, so it go to their database, and then they can assess whether that's an adverse event that they need to look into more. Okay, so that's, I hope, giving you a bit of an indication of where we are currently at with vape use and the current regulations. Let's have a look at safety and advice. So we mentioned before that around 10 years ago, Public Health England stated that vaping is 95% less harmful than smoking. And the current advice is similar, but it has changed a little bit. So this is the latest from the Office for Health Improvement and Disparities. So they say e-cigarette and e-liquid use is considered significantly less harmful than smoking and is continuously reviewed by the Office for Health Improvement and Disparities. So slightly kind of moving away from putting a figure onto it, but still really important to, I think, emphasize that considered significantly less harmful than smoking. Before I kind of look into the other bits of information on this slide, is anyone aware of any myths associated with vaping? Any common myths that anyone would like to share that you're aware of, or perhaps that participants may have recently, service users may have recently shared with you in clinic? So yeah, that's the key one, isn't it? Yeah, popcorn lung. Yeah, lot of likes for that one. Also, vaping is worse than smoking, so we'll have a look at that in a minute in terms of the ASH survey on perception of harm of vapes compared with smoking. Yeah, you don't know what's in a vape. Yeah, vaping is worse than tobacco smoking. Yeah, so simply people just having that perception that it's worse than tobacco, you know. Well, we'll talk about that, of course, in a moment. Yeah, we'll have a look at that in a moment. Absolutely. Robin, yeah, we don't know the long-term effects of vape. So, you know, that absolutely is true, isn't it? So, you know, currently we're pretty confident that in the short and medium term, there's no significant risk to vape use. However, you know, there are unknowns, and it's important to be honest in that. However, you know, currently it's considered significantly less harmful than smoking. Yeah, happy to take any questions. So let's have a look. Gemma, you've got your hand up. Yes.
I was just wondering, is it still suitable for us to say to patients that vaping is up to 95% less harmful than tobacco? Because I find that has a much bigger impact than saying to people it's significantly less harmful. So I just didn't know what the sort of stance from Reid would be on whether we can still use that sort of 95% figure or not.
Yeah, I would say that we can put it into context. So we can say that, you know, Public Health England, you know, said that it was 95% harmful. However, now since the change in the public health bodies, OHID say that it's significantly less harmful. So I think we don't want to kind of go back to the old 95% because that's not the current standpoint. We kind of want to go with the kind of current standpoint of the kind of guidance. And the people who are reviewing vapes on a regular basis. However, we do want to say that, you know, since the vaping use has been established, we have always been, or there has always been the view that smoking is significantly less harmful than smoking. So yeah, that it is a much better selling point with that number, 95%. But I think for now we do just have to keep with that significantly less harmful, just because that's the current standpoint. But really good question. Really good question.
Thank you.
Angela, yes. Yeah.
Hi, Dale. So apologies if you are going to go on to cover this. I just thought it would be helpful to know when we're discussing options with patients and participants, and they want to know what the known risks of vaping are you able to provide any of the known risks with vaping, or is there anywhere that we can actually go to read these? Because it's something that I found quite hard to get a hold of. Obviously, we're not going to focus on all of the negatives, and it's just to give them an informed decision. An informed choice.
Yeah. I agree with you. It is hard to get hold of a kind of consistent message in terms of risks that we're aware of. We're certainly aware of kind of hypothetical risks. So, what risks may kind of certain flavors pose or things like that in the future. But in terms of kind of current risks, there's quite limited information on that at the moment. Just for kind of insight moving forwards, I am planning to create a, just like we have kind of guidance, internal guidance on kind of prescription only medications and things like that. I am hoping to develop a specific protocol for e-cigarettes, which I hope will include some of those kind of recent, some of those kind of potential effects that we may know. So it's in a easy to find place, but it is quite hard to find that information. And you're right. I think that potentially is because we're trying to not dwell on any negatives, albeit most of these negatives are hypothetical. So the standpoint from NCSC2 certainly is focus on the facts and what we know right now about smoking, and we'll have a look at some points here that will absolutely go some way to address that, and not focusing on hypothetical or kind of chance of things happening in the future, because we do know that smoking using e-cigarettes is less harmful than consuming carbon monoxide and the 7,000 plus 4,000 to 7,000 plus chemicals within tobacco cigarettes. But yeah, really good question. We'll come on to this in a little bit. What we are missing is that kind of long-term study, because I think I mentioned it on the last tobacco treating tobacco dependency training. When we're talking about vapes, we're kind of weaving in lots of different points, lots of different kind of research and things like that. It will be brilliant, in the future. There is a study being commissioned that will, give us that kind of long-term use confidence. Robin, you've got your hand up. Yes.
Hi, yeah. I guess as a talking point, it's a tricky one with vapes, because there's a bit of a juxtaposition in terms of it, that like the evidence is that people are more successful with stopping smoking by using a vape, but at the same time, the people who say have never sort of smoked or never vaped are sorry that those figures are going up, and so they're obviously trying to introduce a lot of guidelines and legislation and regulation around that to minimize it. So I guess it's a tricky one to have that balancing act, especially when we're providing vapes to people, and it's sort of still sort of keeping that sort of similar action going there, which for some people is useful, and some people they want to get away from that. So I guess it's a bit of a balancing act with that.
Yeah, I think that's a really good point. And what we do know, everyone, is that vaping is not risk-free. We're not saying that vaping is healthy, full stop. But what we do know, or what the kind of advice is, that it's likely to be significantly less harmful. And you're absolutely right, Robin. Really important to kind of situate it in terms of that, point around it is the most popular method used to stop smoking. And in the last kind of year or so, in settings such as our services, it has been the most effective, absolutely. So definitely a bit of a balancing act, but of course, the treatment choice is also for our participants. So of course it's important, and we'll address some of these myths that you've kind of shared in a moment. Important that we kind of address those myths, but ultimately, of course, it is our participants' decision, bar any kind of cautions or contraindications as to the treatment that they choose. So yeah, some really good points, everyone. Really good to have a kind of good discussion regarding vapes. Let's have a look at some of the key myths. So firstly, popcorn lung. So that was mentioned a few times. So yeah, really important to address popcorn lung. So popcorn lung came from popcorn factory workers in Eastern Europe. They were exposed to a chemical called diacetyl, and that caused acute lung injury. And the reason why it's called popcorn lung is because diacetyl was a chemical used to create a buttery taste in popcorn. So excess kind of inhalation of those chemicals cause acute injury. diacetyl is not is a banned substance in e-liquid, so it's not something that if people are purchasing regulated and licensed e-cigarettes, it's not something that anyone would ever come across. But of course, in terms of that kind of news story, that popcorn lung did fly and has still kind of sustained a little bit. But yeah, it was due to that chemical diacetyl. Workers in a popcorn factory, diacetyl gives an artificial buttery taste, and exposure to that chemical caused the acute lung injury, not e-cigarettes. The other one is so in the US, there was a reported outbreak of kind of vaping deaths, an outbreak of acute lung injury, that was initially associated with vaping. This was in the US, as I say. So it was an outbreak of serious lung injury leading to over 50 deaths. It was originally attributed to nicotine vaping, but later confirmed by the US Centre for Disease Control to be associated with only vaping illicit THC e-liquids containing vitamin E acetate. And again, these are both banned ingredients for e-cigarettes in the UK, and no similar outbreak in the UK. So that's another key one that often is mentioned. In terms of safety of e-cigarettes, so there has been kind of known causes of e-cigarettes kind of leading to fires and things like that. It's important with e-cigarettes that we treat them as carefully as we would any other electronic device, that they don't get we're not leaving them in a warm place exposed to the sun. We're not leaving them charged unattended. Most of the, if not all of the kind of instances where there was an issue with these vapes was due to modification of the vapes, so changing the battery power, modifying the kind of heating element of the e-cigarettes, kind of not using using aftermarket parts essentially. So yeah, really important to be aware of that. There's no significant link to that with using e-cigarettes in a proper way. So yeah, I agree, Ruth. We do have that big kind of nicotine withdrawal. That nicotine withdrawal protocol document, and I would like to put kind of e-cigarettes outside of that if I can, to provide a bit more kind of guidance. So really good. Agta, so we'll come on to the review in a moment. Should we advise limiting use to no longer than 2 years due to lack of information on safety beyond that period? There's no kind of guidance on that. So the guidance still is that if you are a smoker or an ex-smoker, vaping is still a great tool for you, and to use the e-cigarettes for as long as you feel you need to sustain that quit, to abstain from smoking. That still is the guidance and the advice, but certainly we'll learn more about the long-term use as more studies get commissioned, and we'll come to those in a moment. Just to provide hopefully a bit of a kind of helpful bit of information in terms of chemicals in cigarettes versus e-cigarettes. So this was presented at the again the SCTRP update last year. So in terms of carbon monoxide, so e-cigarette smoking versus e-cigarette, carbon monoxide all gone. Particulate matter about 10% lower. More importantly, mostly just liquid particles or chemicals with low or no risk. Free radicals, so kind of carcinogens, less than 1% of in e-cigarettes compared to cigarettes. Nitric oxide, apologies, it's a bit chopped off there, all gone. Tobacco specific nitrosamines, between 100 to 1,000 times lower, and volatile organic compounds such as aldehydes only occur when frying the e-liquid. So there has been some kind of information out there around kind of heavy metals in e-cigarettes. e-cigarettes and some of these kind of volatile organic compounds, usually they only occur with either a dry draw of an e-cigarette, so drawing on an e-cigarette with hardly any kind of e-liquid in it that causes it to fry and produces those chemicals, or taking a dry draw from an e-cigarette, as long as the vape liquid is topped up, that shouldn't occur. So hopefully that just gives some kind of additional context around some of the chemicals and in cigarettes versus e-cigarettes. In terms of the Cochrane review, so yeah, really important to kind of stress some of the outcomes of the recent 2024 Cochrane review update on e-cigarette safety. So let's have a look. So of course, this is assessing e-cigarette use in the short to medium term, up to 2 years of use. And they concluded from their report that there's high certainty evidence that nicotine e-cigarettes are more effective than traditional NRT, such as patches and gum, in helping people to quit smoking. People using nicotine e-cigarettes were more likely to stop smoking for at least 6 months compared to those using NRT or non-nicotine e-cigarettes. Data suggests that if 6 in 100 quit using NRT, 8 in 12 would quit using e-cigarettes. That's an additional 2 to 6 quitters per 100 people. And in terms of safety, they say there's moderate certainty evidence that the rate of adverse effects is similar between nicotine e-cigarettes and other cessation methods. No significant difference between, for example, e-cigs and NRT. The Cochrane review does highlight the potential of e-cigarettes as absolutely a valuable tool for smoking cessation, and yet no serious risks were detected for up to 2 years. Some risks may yet emerge, they say, so flavorings, impurities, metals from devices, overheated e-liquid. However, hopefully with kind of proper use of the vapes and kind of education around that, using only properly regulated vapes with legitimate e-liquids, of course, that's going to minimize the risk even further. Of course, if people get e-cigarettes in an illegitimate way or purchase e-liquids with other substances such as THC, cannabis, and others, then of course that's going to heighten the risk. So yeah, that's the kind of standpoint from the Cochrane review. Let's have a look. Gemma, I've just seen your message in the chat. So you mentioned, yeah, you try and explain the length of vape use like NRT and prescription-only medications as there for sustained periods. Vaping can be, but it doesn't have to be. Yeah, so that's absolutely right. For me, certainly when I was delivering smoking cessation, it felt like quite a common sense approach to, of course, we want to start people, if they are using e-cigarettes, on a suitable dose of nicotine to give them the best chance of quitting. However, potentially after that 4-week quit point, of course, there's no kind of fixed structure to this, but of course, we might encourage participants to say, okay, if you feel quite comfortable with the way things are going with your e-cigarette, how about not going down the next notch of nicotine liquid, going from an 18 to a 15 and so on and so forth, at levels that the participant feels comfortable with, and at levels that mean there isn't an increased likelihood of returning to smoking. So I think, Gemma, that is a good approach. There's no kind of one size fits all, so I can't offer, week 1 and 2 is, this and so on and so forth. But, that's something that we may come across a bit more when we talk about innovation a little bit later on. But yeah, there are lots of questions, and I really hope that's started or kind of reminded you of some of the key points in e-cigarettes. Hopefully, things will become clearer as kind of more research is out there. Just in terms of the kind of perception of harm of e-cigarettes compared with tobacco cigarettes, so perception of harm has kind of undulated over time. However, 50% of people believe that vapes are a lot more or equally as harmful as e-cigarettes, and we are very confident that that's not the case, that e-cigarettes are significantly less harmful than smoking. So, certainly in terms of our role as stop smoking coaches, of course, it is the participant's choice in terms of the treatments that we have available, what treatment that they go for. But of course, where we hear these kind of myths and other statements, it's important that we are aware of how we can manage those and have a kind of pros and cons discussion, but always ensuring that participants are in control of their choice in terms of the treatment that they opt for. So those are some initial thoughts, everyone, on kind of safety and advice. Everyone, any questions before we move on to the next slide? Okay. So just a bit of information on youth vaping, 11 to 17-year-olds. So again, this was a recent study last year from Action on Smoking and Health. They found that rates of vaping among 11 to 17-year-olds has stabilized. So it was around 7.2% in 2024. However, 18% of 11 to 17-year-olds are ever vapers. So 18% of 11 to 17-year-olds have tried an e-cigarette or experimented. Yeah. In terms of 11 to 17-year-olds experimenting with vapes, it was 9.5% in 2024 compared with 11.6% in 2023. So potentially positive that has reduced, the number of people experimenting with vapes has reduced slightly. And 72%, this is something that hopefully will be targeted in the tobacco and vapes bill, 72% of 11 to 17-year-olds report that they were exposed to some form of vape promotion. Okay, we can see from the graph that in terms of current use of vapes in young people, in 2021 we did see quite a significant increase from 3.2% to 6.9% in 2022. However, rates have stabilized since then. Of course, with the introduction of the tobacco and vapes bill, the disposable vapes ban, it will be interesting to see how these figures change over time. Would anyone like to kind of share any guesses? So does anyone have any particular concerns about kind of youth vaping? Well, of course, there are significant concerns about youth vaping, and we'll come across that in the key messages on the next slide. But would anyone like to kind of share any thoughts in terms of, where they think youth vaping may go in the next few years? I'll give you a few moments to have a think. No worries if you're not sure. Just a bit of an open question, really. We don't know yet, quite hypothetical, but good to have some kind of thoughts, really. Anjali, yes, go for it. Yeah.
Yeah, it's a really interesting and important topic. I've had one young person come through our young person pathway so far, and she successfully quit smoking, but she also vaped, and it was slightly challenging because we don't have sort of any vape guidance within our program yet, in terms of reducing the amount of nicotine that she's having, or sort of specifically around that kind of under 18 age group. It was something I had to kind of just not really include in her program, or acknowledge, even though it was something that was massively helping her stay smoke free. Yeah, it was a really tough one, because it's something that we shouldn't really encourage under 18s to do, but if it plays a big part in their journey to being smoke free, it can't really be ignored. So I think part of like our country's drive to bring consuming tobacco down, we are kind of feels a little bit like we're throwing a lot of vapes at people, and without the kind of tailored support around young people to be able to pull the reins back on it, other than just giving that behavioral support.
Exactly. I think that's a really good point. And there is kind of emerging evidence around efficacy of using NRT and as a way that someone might come off vapes. There's also research into kind of cytosine and varenicline as well, but that's not established yet. And of course, as Stop Smoking Services, we're funded to offer treatment in terms of offering NRT and things like that to people who are wanting to quit tobacco. And currently, it's not established that kind of pathway to support people who potentially, we're focusing here on kind of youth vaping, what their kind of next steps are beyond, of course, the behavioural support that we already offer. So definitely that there's something that, we'll talk about in the kind of final part of this session in terms of what approaches we might take moving forwards around addressing youth vaping, for sure. But yeah, really great points, Angela. I'm sure quite a few in the team will have come across similar issues. And Gemma, yeah, education is so important. So we have actually already had some conversations with commissioners in Kensington, Westminster and Chelsea around potential kind of education workshops for young people. So that may be something in the pipeline, because that is crucial for tackling youth vaping as well as the legislation. Okay. I just thought I'd highlight everyone some kind of research that was presented at the Smoking Cessation and Health Conference earlier this year. So this was from Dr. Jasmine Kuja from the University of Bristol, and they carried out some research around kind of youth vaping, and they assessed some young people who both kind of had or hadn't had experience with vaping around their thoughts in terms of the disposable vape ban and what would be helpful for young people to ensure that they don't take up vaping or they get support to stop vaping. So just a bit of a summary from that research. So in terms of the impact of banning flavors in vapes, so the good points, the gateway, a potential gateway to vaping for some people avoided, and non-smokers protected from vaping. However, in terms of some negatives, is there perhaps an increased likelihood of relapse to smoking, potentially quit attempts lost for those that would have used a vape if they had the available flavors. And there were some concerns within the study that they completed where younger adults said that they may go back to smoking with the disposable vapes ban. There are some case studies where there have been kind of flavors banned, and also kind of stricter regulation in terms of e-cigarette flavors and things like that in other countries. So specifically in San Francisco in the US, they saw a reduction in vaping, however found an increase in smoking. And in Finland, a study said that 43% of vapers have used illicit products in the last year. Of course, we did discuss some kind of measures that hopefully will kind of mitigate these unintended consequences of the tobacco and vape field, but this is definitely worth being aware of, and something that we need to kind of keep an eye on and make sure that the support is there for those to ensure that they don't go to those tobacco products at a young age or illicit products. There were some suggestions from young people in terms of support. So important not to kind of preach or be patronizing. Potentially schools or colleges should confiscate vapes. I'm surprised where that may not already be happening, but that was an interesting point. And young people educated about impact of vaping. So of course, we're not really discussing too many solutions there. This is an emerging topic, I would suggest, but something that hopefully will develop and may have kind of more effective support for moving forwards. Okay. Let's have a look. So yeah, I just thought I'd finish off with some key messages and kind of things to look out for. So some of the key messages is that, yeah, e-cigarettes are an effective tool to stop smoking and are likely to be significantly less harmful than smoking tobacco. A good message here If you smoke, vaping is a good option. If you have never smoked, never vape. And of course, some risks may yet emerge, as we discussed. However, it's important, this is from the NCSET, important to focus on what we know now instead of kind of undue focus given to hypothetical or potential risks. In terms of long-term studies, the good news is that recently the government launched a 62 million research project to investigate the long-term health effects of vaping on young people. They're going to aim to track 100,000 young people aged 6 to 18 over a decade. Of course, with these long-term studies, we're not going to get the results very quickly, but this is kind of more of what we need to be even more confident with the safety and efficacy of vapes. And I thought I'd just mention a study that recently gained kind of media attention, the Manchester Metropolitan University study into long-term use of vaping. So this is, I'm not sure if anyone saw this or was aware of it, but much of the information I'm taking here is from Action on Smoking and Health. So I'm not aware that the study is peer-reviewed yet. However, the participants within this Manchester Met University study were aged between 18 to 45, and the kind of main test was measuring blood vessel elasticity and brain blood flow in those who use vapes. And the media coverage that has kind of stemmed from that suggests vaping induces an effect in terms of vascular health similar to smoking. However, the study includes ex-smokers and concurrent tobacco users and vape users. So there's possible kind of ambiguity there between the effects of smoking and what is the effects of vaping. So this research isn't yet published, but I thought I had to mention it here because it did, for a week or two, kind of gain some attention. But yeah, Action on Smoking and Health and lung cancer specialists stress the importance regarding misinterpretation of those findings. Of course, need to differentiate the use of vaping as a cessation tool, and of course, reducing appeal to non-smokers, particularly young people. Okay. So I hope that's okay, everyone. I think that's the final slide that I've got for an e-cigarette update. Does anyone have any questions before we move on to the next slide? Just pause in case anyone's got any questions, and then we're going to go into prescription-only medications. Okay. All right, let's go. Okay. All right, everyone. So prescription-only medication update. So in this section, we are going to go into as much detail as we can around these medications. So we're going to have a look at all of these treatments that are now licensed or have been licensed by the MHRA or reintroduced and added back onto the guidance. We're going to have a look at the mechanism of action of these products, how they help people stop smoking. We'll then look at the usage and side effects of these treatments, the dosing schedules. We'll look at cautions, contraindications. I've put a bit of a kind of resource together around how we request these treatments, and also some information from NCSET, a bit of an update in terms of the kind of hierarchy of treatments used in smoking cessation services, what's first line, what's second line, things like that. So just to get us started, so prescription-only medications, everyone, are medications that require a prescription from a qualified health professional, such as doctor, dentist, or nurse, before they can be dispensed, and they're not available for purchase without valid prescription. And there are now 3 licensed prescription-only medications available in the UK for supporting smoking cessations. So we've got cytosine, which isn't a new treatment, but it's quite new to the UK. We've got Varenicline, which again isn't new, but last year was reintroduced. And then we've got bupropion or Zyban, which again has been around for a little while. It did take a bit of the kind of prescription only medication load whilst varenicline was withdrawn, but now potentially maybe seen as a bit of a kind of third choice moving forwards. And these medications are all licensed by the MHRA and approved by NICE. And we'll have a look at the mechanism of action shortly, but in brief, these medications work by interfering in some way with the nicotine receptors or with the reuptake of dopamine to reduce withdrawal symptoms without providing a supply of nicotine. So whereas, of course, e-cigarettes and nicotine replacement treatment provide a cleaner form of nicotine to replace the nicotine that they would otherwise get from tobacco cigarettes. These are a non-nicotine medication and work by directly impacting on the nicotine receptors and the reward system of tobacco smoking. I'm aware, of course, as we go into this topic, it's a bit of a mixed picture among our services. So I know Leeds, you do have kind of all of these treatments on the program. However, I'm aware of some kind of challenges and difficulties, bureaucracy and things like that, that's involved with that there. Norfolk, I know you have been kind of offering Zyban recently. I believe you added, I think, varenicline, was it, to the program? Do correct me if that's wrong. And one you Kensington, Chelsea and Westminster, just a few weeks ago, I delivered an update for you all on cytosine because that medication was, I think, introduced a week or two ago. So a bit of a mixed picture. Some of our services, of course, by process of elimination, aren't offering prescription-only medications, but I know there is some work in the background in terms of getting GPs on the side, commissioners as well, making sure that they're ensuring that we're able to offer this treatment, because of course until we're able to offer these treatments, we're not providing the full range of pharmacotherapy that is available to people who smoke in the UK. Let's move on to, I think, the mode of mechanism of action next. So what I thought it was helpful to do first, I apologise, this is quite a busy slide. What I thought I'd do is just kind of share the mechanism of action. So firstly, we're going to talk about cytosine and varenicline. We'll talk about Zyban in a moment. It's helpful just to kind of put it into context in terms of the nicotine and addiction cycle. So of course, as many of us will know, as soon as we consume a tobacco product, whether that's a cigarette or a smokeless tobacco product, of course, nicotine gets absorbed into our blood plasma. The nicotine then travels and kind of intercepts with our nicotine alpha-4 beta-2 receptors. Once they kind of attach to those receptors, dopamine is released, of course, providing that feel-good factor. Of course, dopamine doesn't last very long, therefore dopamine levels drops, therefore withdrawal ensues. Therefore we think, hang on a minute, I'm not feeling too great right now, I want to feel like I did a few minutes ago. Then the cycle kind of continues with continuing that use of the tobacco product. Of course, it's generally considered the more someone smokes and the longer someone smokes for, the more dependent they may be due to more nicotine receptors and of course the withdrawal cravings that they get from smoking. So in brief, there's a bit more detail to that, but that's just a bit of an overview. In terms of cytosine and varenicline, how do they work? So let's say we take cytosine or varenicline. Cytosine or varenicline binds to those nicotine receptors, and the receptors do release dopamine, but much less so than nicotine. Therefore, nicotine withdrawal is alleviated. If someone continues smoking using these products after a certain number of days, smoking does actually become unpleasant. And as soon as someone stops smoking, stops their use of nicotine, their use of tobacco, nicotine receptors will start to kind of close and become dormant. That's not kind of closed forever. So if someone does have a cigarette again, that will kind of open them all up. And very often people will go back to their previous behavior in terms of smoking. But that's just in brief, everyone, how kind of cytosine and varenicline works, alleviating nicotine withdrawal by kind of acting intercepting those kind of nicotine receptors to alleviate that nicotine withdrawal. Okay. Let's firstly have a look at cytosine. Okay, so although cytosine is relatively new to the UK, cytosine has been used to support people to quit for many years. So cytosine is derived from a naturally occurring alkaloid from the seeds of plants, including laburnum, and laburnum is also known as golden rain. And during World War II, soldiers ate the seeds of laburnum and found that it actually had an effect of kind of reducing smoking cravings and reducing smoking behavior. So in the 1950s, cytosine was first synthesized, and in 1964, cytosine was first marketed in Bulgaria under the brand name Tabex. In the 1970s onwards, it was widely adopted in kind of Eastern Europe for smoking cessation, particularly Poland. Canada also has been using cytosine for a little while as well. In the late 90s, early 2000s, cytosine gained attention in other parts of the world due to its potential effectiveness, due to more trials and studies. In March 2019, cytosine received approval from the MHRA, and in January of last year, cytosine officially launched in the UK, making it available on prescription. And in February of this year, it was added to the NICE guidelines as well. Okay, so cytosine, of course, as all of these treatments are a kind of tablet medication, prescription-only medication, used for many years, but quite new in terms of the UK. Let's move on to the next slide. So in terms of the usage and side effects, so the standard course of treatment, everyone, for cytosine is 25 days. It's quite a short course, and it's prescribed for use from 5 days prior to quit date. So what does that mean? So when someone starts their course of cytosine, they must quit. They must stop smoking no later than day 5 of taking the medication. And the dosing schedule is a little bit complicated compared with other prescription-only medications, but potentially there is a bit of a kind of similarity in terms of when people are taking these tablets and when they may have smoked previously. So there are kind of positives and negatives. So the dose starts with 6 1.5 milligram tablets a day, and over the 25-day course, it reduces to 1 to 2 tablets a day. The tablet should be taken with water, with or without food, preferably taken with food to reduce any kind of gastrointestinal kind of side effects. Tablets should be stored appropriately, and people who use cytosine shouldn't take more than the recommended dose. Participants shouldn't double dose. If they miss a dose, they should just wait till the next scheduled dose and take it as usual thereafter. In terms of side effects, of course, as with any medication, there are side effects. We've just kind of highlighted some of the common ones here that are expected to subside within 2 weeks. In terms of gastrointestinal problems, they're usually alleviated by kind of eating before taking the treatments. So yeah, I haven't added a kind of full list of side effects there. They are all on the either our Read Wellbeing cytosine coach guidance or on the NICE clinical knowledge summaries as well. Okay. So yeah, we've just got a bit of detail here on the right-hand side in terms of dosing schedule. So yeah, as I said before, days 1 to 3, 1 tablet every 2 hours, max 6 tablets a day. Day 4 to 12, 1 tablet every 2.5 hours, 5 tablets a day. 13 to 16, 1 tablet every 3 hours, 4 tablets. 17 to 20, 1 tablet every 5 hours, 3 tablets. And day 21 to 25, 1 to 2 tablets per day, 2 tablets. We'll have, I'll just kind of show you some kind of dosing guides. So that's something that participants can use to help maintain this schedule. I mentioned side effects briefly. Cytosine is actually, compared with the other treatments that we're having a look at, cytosine is considered to have fewer side effects than, for example, varenicline. So potentially cytosine could be a good option if someone can't tolerate varenicline, but they still want to use a prescription-only medication. Cytosine could be a good option. Just some further information. If someone uses a course of cytosine and they fail that quit attempt, they can't then, or they're not recommended to start another course of cytosine for 2 to 3 months. So there has to be a significant gap between cytosine courses. And just a bit of kind of information, it is generally considered that cytosine probably would be more effective with a more normal kind of duration of treatment, for example, 12 weeks. However, because it hasn't been licensed in that way, and it would take a lot of cost a lot of money to change the packaging and things like that, it's not something that we can recommend to participants. But of course, if anyone uses cytosine and they would like an extended unlicensed course of treatment, they may be able to speak to their GP, but that's not something that we could offer. But cytosine is an effective treatment. We'll talk about the efficacy a little bit later. This is just one option. Let's have a look at varenicline. And varenicline, many of you may know, was known as Champix, but has, since it was reintroduced last year, it's now just a generic varenicline medication. It was previously known as Champix when produced by Pfizer. It has always been considered one of the most effective stop smoking aids, so it's great to have it back. And it was reintroduced in the UK last year, and no significant difference in terms of the medication specifications since it was reintroduced. It was removed from the market due to the potential for nitrosamine impurities, so potential for an excess of cancer-causing carcinogens essentially within the product. However, since it's been reintroduced, it's been deemed that it doesn't have unsafe levels of nitrosamine impurities, so absolutely it's good to go as a stop smoking medication moving forwards. Just a bit of a kind of varenicline development timeline. So in 2006, varenicline was marketed as Champix and approved for use in the UK. In 2007, NICE published guidance recommending varenicline as a stop smoking aid. Now, this is definitely an important one just to mention. So in 2016, or potentially a little bit before that, there was an EAGLE study commissioned to reassess the neuropsychiatric safety and efficacy of smoking cessation treatments, including varenicline, Zyban, and nicotine replacement treatment, because there used to be both the European Medical Agency and the FDA in America. They had a kind of black triangle warning on varenicline and also I think Zyban due to concerns about kind of mental health impacts. However, following the EAGLES trial, they found no significant link between varenicline and serious neuropsychiatric events, and no significant difference between varenicline NRT or Zyban. The trial included 8,000 participants from 16 countries, and following this, the European Medical Agency removed that black triangle warning. It's still something that people are concerned about, prescribers sometimes are concerned about, but the EAGLE study has absolutely been kind of accepted and adopted by NICE and NCSET and all the main kind of tobacco and smoking cessation guidance. In 2021, as I mentioned, Champix was withdrawn. However, last year Champix has been reintroduced. Let's have a look at the usage and side effects. So a bit of a different approach to varenicline compared to cytosine. So the standard course of treatment is 12 weeks. There is an option for kind of an extended course if someone needs it, but that would have to be going through GP potentially. And it's prescribed for use from 2 weeks prior to quit date. So whereas cytosine is prescribed from 5 days prior to quit date, with varenicline, the recommendation is to quit between days 8 and 14. It's worth saying that if someone was to continue smoking after those recommended points, it's likely that they would get quite a metallic taste unpleasant taste when they're smoking. They may also get headaches as well when they're smoking because their body's trying to kind of get rid of that excess nicotine that the body doesn't want anymore. So that can be an interesting effect if someone does continue to smoke past the recommended quit. Titrated dosages are from 1 0.5 milligram tablet a day to 2 1 milligram tablets per day. So for days 1 to 3, for the first week, a participant can continue smoking. They just take 1 0.5 milligram tablet a day. From days 4 to 7, again, they can still smoke if their quit date is after that point. However, they move up to 2 0.5 milligram tablets a day, which are 8 hours apart, preferably at least 3 hours before bed. The second tablet, just to reduce the common side effect of varenicline, which can be vivid dreams. And from day 8 to the end of the course, so from day 8, this is when we really want to think about quitting. It's 2 times 1 milligram tablets a day, again, 8 hours apart. Preferably taken with water, not on an empty stomach, again, to avoid any gastrointestinal side effects. And if someone experiences adverse effects, there is an option to bring someone down from a 1 milligram dose to a 0.5 milligram dose, which may be more tolerable. And there is a recommendation, this is from NICE now, that if in those that have severe renal impairment, we can prescribe varenicline with caution. However, the dosing schedule should be 0.5 milligrams once a day for 3 days and 1 milligram once a day thereafter for the rest of the course. We've got some common side effects here. Again, always with side effects of these medications, important to kind of differentiate between what's a side effect on the medication, what may be a withdrawal symptom. Of course, if anyone experiences any, side effects that are unexpected, that we don't think are withdrawal, that we think are due to the varenicline and they're intolerable, we should be encouraging participants to immediately stop taking the treatment, and if it's urgent, of course, seek advice from GP 111, and of course we can support that participant to find other options if needed. Gemma, when did the stance change on severe renal impairment? So I was previously only aware, of course, in terms of kind of Zyban, kind of having a reduced dose for kind of renal impairment. I think that stance has probably changed since the medication has been reintroduced. I'm not 100% sure, Gemma, when that happened, but that information is from the NICE clinical knowledge summary. So interesting. Interesting. Not sure exactly when that was, but that is the recommendation. Robin, you've got your hand up.
Hi Dale. Yeah, sorry, you may be coming on to this, so apologies in advance if you are. But I was just sort of wondering, because I'm from the Norfolk team and we're not sort of yet at the point of prescribing or putting prescription requests in for cytosine, what the efficacy was between varenicline and cytosine, and sort of the reasoning behind it only being a sort of 25-day course for cytosine. Obviously, if they share similar mechanisms for stimulating dopamine whilst the receptors shut down, why it would only be sort of 25 days as opposed to the 12 weeks of varenicline. An additional onto that, I was just sort of wondering in terms of compliance of taking the tablets of sort of 6 tablets a day to begin with, whether the other teams have sort of experienced any sort of compliance issues with the ability of and the logistics of taking them as often as that.
Yeah, definitely good to have some thoughts on that if anyone has any, if you are prescribing cytosine. In terms of efficacy, in short, I will share an NCSET table which mentions this. So it's very similar in terms of the efficacy, in short, but we'll have a look at that in a moment. And in terms of the reasoning behind the kind of 25-day course, I'm not fully aware of that. I only am aware that that was the kind of accepted dosage in how cytosine has been used previously. And really, when I was on the SCTRP update last year, really they were kind of potentially moving towards simply kind of bureaucracy and the cost of changing the packaging and the licensing for 12 weeks. So in addition to that, I'm not 100% sure, but for now it is just 25 days for cytosine. Gemma.
Sorry, just going back to the renal impairment with the changes there. With the 2 patients that I've had recently, one I refused to request it to the GP because of that, and the other, the GP actually came back and rejected it. Are we able to go back to them or go back to the patient to say there is a more sort of recent research and update on this to maybe discuss with the GP, or are we going to be treading on toes doing that? Because both of my patients have since decided if they can't have varenicline, they won't quit at all. So for those patients, this could have obviously had a really big impact on them if they were able to start it on that reduced dose.
Really difficult in terms of how we go back to that. Of course, there may be other reasons for kind of rejection. What we could do perhaps as a minimum is say, okay, thank you for taking time to review that medication. The reason for the request was due to this being what I'm aware of in terms of their medical history, that they only have a kind of caution criteria, not a contraindication. They are unlikely to stop smoking without using that treatment. Would you be able to review that? I'm potentially thinking off the top of my head there a little bit. It is definitely something that we don't want to tread on any toes, and kind of respect the prescriber's responsibility in what they're doing in prescribing the treatment and their kind of views and things like that. But of course, it's never a bad idea to, of course, share the latest evidence that we're aware of, and see what they say after that, potentially.
Did you say that was on the NCSCT website? Sorry.
Yeah, clinical knowledge summary. I think it's also included on the NCSCT. It's on the NICE, National Institute for Clinical and Health Excellence, clinical knowledge summary for prescribing varenicline. This is what I've got all the kind of up-to-date information on these slides on prescription-only medications for. But yes, I also believe it's on the NCSCT update guidance, but that's a little bit more out of date. The NICE guidance was updated earlier this year.
Okay, thank you.
Robin, yes.
Sorry again. Just following on from that, really, because we had sort of similar challenges surrounding GPs prescribing varenicline when they had the potential adverse reactions to psychiatric events happening, and we, in order to help GPs prescribe or be more reassured and open to prescribing, we then often included the EAGLES study to help with that. So potentially with renal update, it might be prudent or an idea to perhaps include that in part of our requests, so it gives them a bit more to go on, especially if they're sort of using historical information and guidelines in prescribing.
No, I've been aware kind of recently, just in the last few months, where specialist pharmacy teams in their kind of product list still have the black triangle warning for varenicline, even though that was removed quite a few years ago. So definitely, if we feel that there is a kind of no justifiable reason in terms of what we are aware in terms of the medical history. Of course, we don't have access to medical records, but in terms of what participants have verbally kind of shared with us and the program support team when they've kind of joined our service, it's always good to kind of share the most up-to-date research that we're aware of, but ultimately, respect the prescriber's decision, of course, at the end of the day. But yeah, really good questions, and hopefully, as we are using these prescription-only medications more and more and more, hopefully we will find less and less hiccups or barriers to prescribing. Okay, to requesting. Okay, just quickly on Zyban. So Zyban, everyone, the kind of generic name is bupropion, sorry, and it was kind of first developed really in 1966 and patented in 1974. I can't remember the name of the company that first synthesized the medication, but they became kind of GlaxoSmithKline. Interestingly, Zyban, we've been talking about kind of mental health and psychiatric effects of medications already. Zyban was originally developed as an antidepressant. However, it was found as a kind of subsequent, as a secondary effect, that it helped to reduce nicotine cravings and manage withdrawal symptoms. It's still actually a licensed medication for treating depression in the US now. So in terms of the UK, bupropion was marketed as Zyban and introduced to the UK 2001. So it has been around for a little while. NICE recommended Zyban as an effective aid for smoking cessation. Again, Zyban was involved in the EAGLE study, and again, no significant risk highlighted. However, there has always been a bit of a caution around Zyban because of its history as an antidepressant in any case. Zyban was withdrawn, similar reasons to varenicline in 2022, but was reintroduced by GSK in 2023. Zyban, was of course for a period of time, the only prescription-only medication available when varenicline was withdrawn before cytosine was introduced. Of course, still, it is an effective stop smoking aid, absolutely, but potentially, and certainly the kind of the views that I've had from kind of recent NCSET updates and the conferences that I've attended, potentially it's the kind of second line behind kind of varenicline and cytosine now. But of course, if it's the only prescription-only medication in terms of the program, then of course still absolutely a good option for people to stop smoking. In terms of the mechanism of action, it's a bit different to cytosine and varenicline. It doesn't necessarily impact directly on the kind of nicotinell alpha 4 beta 2 receptors. It's generally considered to stop dopamine reuptake. So the essentially it's prevents that kind of dopamine from having the kind of rewarding impact that it would have normally if someone was to be smoking, to take on board nicotine. So essentially Zyban takes away that reward factor from smoking. Okay. Stephanie, okay, that's interesting. Varenicline for patients on SSRIs. That's interesting. I am going to share with you again the NICE CKS cautions and contraindications for these medications. Off the top of my head, I'm not sure if that is included, but we'll have a look. In terms of Zyban usage and side effects, so again, the course is quite different. The standard course of treatment is usually 7 to 9 weeks. And again, similar to varenicline, prescribed for use from 2 weeks prior to quit date. So people using Zyban must quit within 2 weeks of starting the treatment. And the dosages go from 150 milligram tablet a day to 250 milligram tablets a day. Tablets should be taken with water after meals. And again, there is an unlicensed course of treatment, which is up to 24 weeks. Again, participants would have to speak to their GP if they wanted a longer course of Zyban. So yeah, in terms of the dosing schedule, days 1 to 6, 1 times 150 milligram tablet a day. From day 7 until the end of the course, 2 times 150 milligram tablets a day, 8 hours apart. Again, some side effects here, some that are similar to kind of varenicline and cytosine. But yeah, certainly more kind of information on side effects can be found on either NICE clinical knowledge summary for Zyban prescription, or indeed our internal Zyban guidance as well. Okay. All right. Here are some dosing guides, everyone. So I have just kind of squeezed them all onto one page, but these are just some nice dosing guides that we may like to share with participants who are taking these medications. So the cytosine one was produced by NCSCT. Varenicline was produced by the pharmaceutical company, Tabex, I think, and Zyban. Believe it or not, I created this. I couldn't find a good quality kind of Zyban dosing guide, so I've just added a bit of a table there, but it's relatively simple. I think this is particularly useful for cytosine because the dosing guide is potentially more complex than the others, although it is a shorter course. But yeah, definitely important to be aware that these dosing guides are out there and can be used. I think they are certainly cytosine dosing guide is included in the Read Wellbeing Coach guidance. Let's have a look. Yeah, all right. So cautions and contraindications. So I don't think I'll kind of go through all of these, everyone, but I've gone to the NICE CKS for all of the medications that we've just discussed and just added all the relevant cautions and contraindications. Of course, where we identify contraindication, we shouldn't be requesting the treatment. We should be looking at other options. If it's a caution criteria, we can still request, but with caution. There may be reason to go for the lower dose, as we've discussed, or potentially ask a participant to reach out to their GP before requesting to see if there's anything that they need to be aware of or do before that treatment is requested. So in terms of contraindications, so I'm just going to kind of summarize these, I think, if that's okay with everyone, so as not to kind of read them all out. All prescription-only medications used for stop smoking should not be offered for people under the age of 18. And should not be offered for people who are pregnant or breastfeeding or planning to be pregnant around the course of the treatment. In terms of older age groups, so for 65 years and over, that's a contraindication for cytosine. And it's a caution criteria for Zyban. So yeah, over 65, we can't offer cytosine. Zyban is a caution, and varenicline, it's neither a caution or contraindication. There are some potentially we can kind of group some of these kind of cautions and contraindications together. So common cautions for these medications include cardiovascular disease, diabetes, and history of kind of psychiatric illness, kind of renal impairment as well. And I'll just go to Zyban next. There are a few kind of different ones in terms of Zyban. Oh, Anjali, if someone has just turned 65, can we still request cytosine or not worth asking GP? So let me just double check. No, it would be a contraindication for cytosine. So yeah, we wouldn't be able to request it. Yeah. Important to say that with contraindications, yeah, we definitely don't request, just in case, we'll see what they say. Yeah, contraindications are no, let's look at other options. Cautions, however, yeah, we can request with caution. Of course, these slides will be made available, everyone, and that this should all be reflected on the treatment assessment form. Something that I was going to mention a little bit later, but I'll mention now. This is a document that I do want to get into a little bit moving forwards. I haven't modified it too much since I started in this role back in December, but I would like to kind of consider ways to kind of simplify our treatment assessment form, kind of order things a little bit so it's a bit easier to use as well. So potentially, you know, May, kind of June, that's a bit of a kind of project that I would like to start moving forwards. We have had some thoughts, some suggestions, some points in the chat, sorry. Let's have a look. Yeah, Matthew, 64 and 364 days is fine though. Yeah. Let's have a look. Yeah, definitely. So yeah, of course, we do have the coach guidance around kind of Zyban, cytosine and varenicline. However, you know, I'm aware that potentially in terms of our treatment request forms that we email to GPs via a secure NHS inbox, potentially there's something that we can do there to kind of yeah, to make sure that we're including some of the kind of information behind the request as well. So yeah, I apologize, probably won't be able to come up with any solutions, you know, during the session, but it is absolutely, you know, on my mind, definitely in the pipeline to have a bit of a rejig. And of course, if there's any suggestions, you know, I'd definitely welcome that, you know, after today's session in terms of updating our kind of clinic resources and things like that. I'd really like to, you know, work on those, make them as effective and usable as possible. So yeah, definitely something to focus on moving forwards. So these are, yeah, the cautions and contraindications, everyone. I will, of course, share the slides by the end of this week, hopefully. So you'll be able to see these on the slides there. Let's have a look. I'm not going to go through this in loads of detail, but I did this when I was creating the cytosine update for Kensington, Chelsea and Westminster. And I thought what isn't already available is a bit of a kind of flow, kind of decision tree almost in terms of requesting prescription only medication. So what I've just done here, everyone, is of course for us to request treatment we need that commitment to quit. You know, participants need to be aware of all treatment options available, and of course if it's prescription only medications, that's the one that they want to go for. We go through the discussion around the usage, side effects, quit expectations around that around that treatment, and of course check understanding from the participant, and then we complete that treatment assessment form. And what I've just done, everyone, is done a bit of a flow in terms of, okay, if you identify contraindication, what to do. If you identify caution, what to do. If you identify no cautions or contraindications, what to do as well. So in terms of some of the discussions that we've had already, we've probably kind of gone through this already a little bit. And this is something quite new, so something I may develop a bit more moving forward if it's helpful in terms of clinics. Of course, contraindication is quite relatively simple. We don't request that treatment. We look at other alternatives. If it's no caution or contraindication, yeah, let's go with that request. But of course, the prescriber reserves the right not to prescribe if needed, if depending on their decision. In terms of caution criteria, we can still request with caution. In some instances, we would request a kind of lower dose of treatment, and or this isn't mandatory, but we may ask participants to speak to their GP before we request, particularly with kind of medications where someone may need to reduce the dose of a medication that they're already taking. You know, that may be best practice in some cases. So this is early stages really, but I thought I'd include it here. And of course, if it's useful, then potentially we can include this in future protocol moving forwards. Yeah, in terms of prescription request information standard course. So when we were kind of reintroducing some prescription only medications earlier this year, very understandably, I did have some questions about how do we request a medication? You know, is the medication, you know, for 2 weeks? Is it for 4 weeks? How much is within the treatment? So what I've done here, everyone, is just put a bit of a kind of table together summarizing that information. So cytosine, very simple. It's just one request, 100 times 1.5 milligram tablets for the 25 course. For varenicline, it's preferred that the start of the treatment starts with the kind of 2-week starter pack that should be available. There may be some differences in terms of pharmacies, in terms of what is available. I know we do have some pharmacy teams on the call today, so if anyone is aware of any kind of differences in terms of how varenicline is packaged, it is, I know, different to how it was with Champix before, but kind of going on that similar structure. Ideally, the initiation pack for varenicline is 2 weeks to ensure that the treatment's going okay, and to ensure early engagement really on the program in those first stages. Ideally, the second maintenance pack is 2 weeks, just so that, because people won't normally or won't always be quit before we request that second maintenance pack. So 2 weeks would be preferred. We can request 4 weeks, but just to ensure that engagement, to ensure that participants don't smoke for a long period of time whilst using the treatment. And then for the rest of the treatment, up to 2-week course, we can request 4 weeks of treatment. Of course, these prescriptions, unless someone is entitled to free prescriptions, they will have to pay the standard prescription cost. Therefore, definitely, utilizing those 4-week maintenance packs could be quite useful to reduce the cost of prescriptions, even though it's going to be quite insignificant compared to the cost of smoking, likely anyway. In terms of Zyban, there are just 2 prescription requests for Zyban. The first pack, 4 weeks, 60 times 150 milligram tablets. Second pack, again, 4 weeks, 60 times 150 milligram tablets. So that's just the kind of requesting structure, everyone. Hopefully that's some useful information, and will be useful as and when you request these medications moving forwards. Okay. So NCSET treatment advice, hierarchy and efficacy. So NCSET, I apologize again, this table is chopped off a little bit, but NCSET have recently published this table in terms of in their commissioning, monitoring and delivery guidance that they published last year. And they've kind of set out the hierarchy really of treatments used on stop smoking services. So in terms of what they say are first choice stop smoking aids, they are combination NRT, which is of course a patch plus a fast acting NRT product, or nicotine vapes, or prescription only medications, including varenicline and cytosine. So those the NCSET identify are first line treatments. Second choice stop smoking aids are single NRT products, so either the patch alone or a fast acting product alone. And then what's chopped off on the bottom is bupropion. So bupropion is, according to the NCSET, second line now. In terms of the way that we kind of offer our treatments, these are all licensed medications, regulated medications that we can absolutely offer for people to help them stop smoking. However, this hierarchy is just there in terms of the kind of generally considered efficacy of these treatments. So yeah, that's just hopefully a little bit of information in terms of what's first line according to NCSET and what's now second line. But of course, really important that we of course give participants all of the options that are available on the service, and of course encourage participant choice to identify the treatment that would be best for them. Okay. All right, everyone. We are at 12 o'clock, and I think we are at a good time for a break. That was a lot of information with e-cigarettes and prescription-only medications. What I did plan to do before the break is just have a bit of a kind of spotlight on pregnancy and routine and manuals. So what we'll probably do, we'll pause for a quick break if that's okay. Then we'll come back to pregnancy and routine and manual. We'll just go through some key things very quickly. And if we've got time, we'll do a bit of a kind of group activity. If not, we'll go straight into innovation regarding treatments and things like that. So hopefully that's okay, everyone, for this second part of the session. Let's pause for a break. If it's okay, we'll pause for a break between now and 12:10, if that's okay. So do take the time to take your eyes away from the screen, grab a refreshment, and we'll see you for the final part of the session at around 12:10. Thanks, everyone. Thank you. Okie dokie. Welcome back, everyone. We'll make a start very shortly. Home stretch of today's update session. I think what I'm probably going to do, we'll do the two spotlights. We'll just have some discussions around some key priority groups, and then we'll go straight into innovation. We did have a bit of a kind of group activity around having some discussions around kind of successes, challenges, and what you might like to see from me, from the clinical excellent service development team moving forwards. However, I don't want to eat too much into the time that, of course, many of you would have taken for lunch, and hopefully you've got some time out after this training before delivery, or some of you may be munching on lunch right now. So we'll probably go through the kind of main slides and main content. And of course, if after today's session, there's anything you would like some support with, any tools, anything at all from me and the team, and I will reiterate this later, then please do let me know. Okay, so I'm just going to share the screen again on the spotlight, and I just identified that it might be quite useful to have some discussions as a group. This could form part of our sort of kind of group activity almost today, around some key priority groups where our services may be having kind of more emphasis on, or maybe us to kind of prioritize. And of course, pregnancy is always one of the key priority populations that our services are commissioned to support. So just to kind of give you some latest figures, in 2023-2024, 7.4% of mums to be pregnant women were still smoking at the time that they gave birth. So that's still, a significant number. However, it has gone down from 8.8% in 22-23. So great to see those rates declining. We'll talk a little bit about the smoke-free pregnancy incentive scheme in a moment. But what I thought, now that we've got lots of co-members together across lots of our contracts, what specific considerations do you feel are important in terms of your delivery in supporting pregnant service users? So are there any kind of tips or kind of tools that you use to support pregnant participants? Are there any kind of approaches that are different to supporting pregnant service users compared to non-pregnant service users? And as a general rule, in terms of our service delivery, are there specific requirements and considerations we have to be aware of when supporting pregnant service users? So I'm going to give you all some time to have a think. We'll give it at least a couple of minutes. Of course, if anyone would like to share any thoughts around supporting pregnant service users, feel free to do so in the chat, or indeed over the microphone. I'll just pause in case anyone would like to share. Could be potentially the type of support that we offer. Are there kind of any additional pieces of information that we would want to offer these participants? Is there a difference in terms of the way that we deliver our services? How do we best support pregnant service users to be aware of the health risks of smoking? Some of you may be aware of perhaps some kind of challenges. So, do you come across any challenges from pregnant service users? Of course, at the moment, we've got the kind of opt-out referral where, if someone self-reports that they smoke or produce a carbon monoxide reading at a midwifery appointment of 4 parts per million or over, they're automatically put onto an opt-out referral for stop smoking services. So, is there any kind of pushback potentially from those participants? Any additional information? So, first one, thank you, Matthew. So, no prescription only medication requests can be given. Absolutely. So in terms of treatment, absolutely prescription only medications aren't suitable Yeah, Gemma, really important that we are non-judgmental. It's a very hot topic in terms of opinions that people have. Potentially, pregnant smokers are, likely to be one of the most stigmatized groups of smokers. Absolutely. Carbon monoxide readings are super important. Not just measuring the carbon monoxide of exhale breath of that individual participant, but of course that context of the fetal carboxyhemoglobin going to their unborn baby. Absolutely. Lorna, great. Support for pregnant people in Norfolk is now done in-house with their hospital teams. Previously, you found better engagement by phone rather than face-to-face, as they were often feeling judged in waiting rooms. So, that's a really good point. Of course, kind of integration with maternity services is really important for supporting pregnant people. But in terms of thinking about the different ways in which we support, telephone kind of remote appointments are great. Absolutely. Definitely, as kind of Gemma mentioned, some benefits to CO monitoring that are specific to this population, but I think that's really important. That kind of judgment and stigmatization. Debbie, you're honest with them about the dangers of the baby, however, with no judgment. So, of course, in a kind of motivational interview style, where we're kind of first asking participants what they're aware about in terms of health impacts, and of course, asking do you mind if I kind of share some with you if they aren't necessarily forthcoming? Because of course, continuity of information is really important. It's likely that potentially their GP, hopefully, will be sharing that information. It's likely that their midwife will be sharing that information with them. That's why they've been referred to our service. So, that continuity of care is and communication is really important. Some great words coming through. Compassionate, non-judgmental. Thank you, Anjali. Lorna, explanation of the carbon monoxide effects on the baby is often motivational. So talking about that percentage of carboxyhemoglobin is a percentage of red blood cells where oxygen is not going to that baby, so restricting oxygen. So that's a really powerful tool for sure. Anjali, reminding it's never too late to quit. So there is kind of information out there where if pregnant smokers can quit prior to their 15th week, that often leads to the best outcomes. But at any stage of stopping smoking during pregnancy, there will be benefits, absolutely, and it's super important, no matter what trimester, absolutely. Uptake on pregnancy is very low, so engagement can be a bit of an issue. I think, finding different ways in which we kind of engage pregnant participants, potentially, linking in with the incentive scheme may form part of that. But, potentially the word of the kind of incentive scheme isn't, out there very much. Engagement is really important. Let's have a look. Fast engagement with referrals, absolutely. So at the point of referral, as quickly as we can support them, the better, absolutely, to reduce that chance for loss of follow-up or disengagement. Because of course, if someone is told that stopping smoking is really important, however, they're not going to get support for another 4 or 5 weeks, then of course that is a kind of differential in terms of perceived urgency from potentially their midwife team and the support that we're offering. Absolutely. Dispelling myths about pregnancy, absolutely, Lorna. So things such as smoking will mean I have an easier birth because of low birth weight. Absolutely not the case. We may already be aware of many of the complications associated with smoking in pregnancy. Absolutely. Emphasis of support available and kind of really thinking about that support during the program, celebrating milestones, positive affirmations and things like that. And very interesting, Gemma. It's kind of similar point, isn't it, to the GPs in terms of, how informed are kind of the health professionals that we work with around the dangers of smoking, the importance of smoking and the benefits of support. So that's definitely important. We've got so many more. That's amazing. I'm just going to have a look. Such a good one, Reece. So in our services, where we may be commissioned to specifically support pregnant smokers, we're now being encouraged to support the partners of smokers or people in the same household who also smoke as someone who's pregnant. So yeah, that's really important as well. Yeah, absolutely. That's interesting, Ruth. Yeah, midwives don't like vapes. However, yeah, we know e-cigarettes, as we know, are absolutely suitable for pregnant smokers. Absolutely. Great stuff. So many thoughts, everyone. If I've got time in a minute, I will kind of go back through some more, but yeah, so some great thoughts coming through. Thank you all so much. So I've just got a bit of a list here that's absolutely not as conclusive, not as exhaustive as what you've been able to offer. Of course, just in brief, in terms of treatment options, so only nicotine replacement treatment, e-cigarettes, and e-cigarettes are the licensed smoking aids for pregnant participants. In terms of nicotine replacement treatment, of course, offering the 16-hour patch and not the 24-hour patch, and avoiding licorice flavoured NRT products, although I'm not aware that that's available, but that's always something that we add on the assessment form. Yeah, misinformed beliefs such as easier pregnancy, as we mentioned. Yeah, more likely to experience stigma and shame, as we discussed, and likely to require extra support and praise as well. Yeah, a lot of, I think, commonality here in terms of kind of misinformation from kind of health professionals and things like that. So, you know, I suppose that's where we need to kind of look at in terms of training that we can deliver externally, or kind of I know there's a lot of really great work in terms of outreach and engagement into some of these services, but you know, this is a bit of a continuation of the theme from, but yeah. The more that we can do to inform health professionals and ensure that the up-to-date advice is followed, not just in our services, but in with people that we're working with, that's super important. Yeah. In terms of the National Smoke-Free Pregnancy Incentive Scheme, everyone, I just wanted to highlight this. I won't go into loads and loads and loads of detail. However, in terms of this version of the scheme, there has been a few schemes previously. However, this most kind of up-to-date scheme was rolled out in December 2024, and this pregnancy incentive scheme is only eligible for those pregnant smokers who also enroll in behavioural support. The incentive scheme was set up and commissioned by OHID. Primarily, you know, the incentive scheme sits with the NHS, but also funding for the scheme is accessible to local authority services as well. There's an initial kind of 2-year funding, I think up until 2026, I think, for this scheme. And the pay schedule for the incentive scheme is at the start, £20 voucher kind of blocks when someone signs up, then weekly after the quit date, monthly after successful 4-week quit, and then 4 weeks postpartum, so after giving birth, there's a £100 voucher. 12 weeks postpartum, there's a £60 voucher. So this should be available to most pregnant participants. It does vary in terms of the uptake, in terms of NHS services or local authorities that are kind of using this incentive scheme. So I'm not sure of the picture in terms of our services, but it's important to be aware that this is available. This could be a great incentive scheme for pregnant smokers. The vouchers are Love to Shop vouchers. They, of course, can't be used for purchasing tobacco products, alcohol, or gambling. If someone relapses and they start a new quit attempt, they will still be eligible for this incentive scheme, but the vouchers will be discounted to, I think, £10 voucher steps. So it's important to be aware that this is this is out there, this is being run. There, as I say, there may be significant differences in terms of to what extent this is being used, and to what extent kind of midwife teams and things like that are aware that this is available. But really important to say that this is out there, and this could be a really useful incentive scheme to support more pregnant smokers to quit. Okay. Just final kind of spotlight section that I added here is routine and manual. So routine and manual is, again, another priority population where we are being asked in some of our services. I know in Leeds, I think there has been kind of specific requirements to engage with routine and manual workers. I know that that may be similar in other services as well. But this is one of those priority populations that we should be more aware of, and aware of the considerations for supporting these populations. So routine and manual socioeconomic group includes, but it's not limited to, HGV drivers, cleaners, porters, package labourers, waiters or waitress, bar and staff. It really is a broad range of roles that's included within routine and manual. And as we kind of identified earlier today, the routine and manual socioeconomic group has the highest smoking prevalence out of all other socioeconomic groups. Again, just a bit of an activity, everyone. That was really useful with pregnancy. Would anyone like to suggest any specific considerations for supporting people in routine and manual occupations? So again, in terms of our service delivery, in terms of any particular challenges through a quit that a routine and manual worker may have, any differences in terms of the way that we deliver services. So hopefully those are just a few pointers to kind of tee you up a little bit in terms of that. Great to have some thoughts already coming through into the chat. It's great. And great. So workplace clinics. So of course, we'll, I'm sure, have a few more contributions around kind of flexibility and service access. But of course, some routine and manual workers may have really quite tricky shifts or long shifts, which may make it difficult to access services. So potentially integrating into workplace clinics. I know on some of our services, feel free to share if this is correct, if there's any more information behind this. I know that some of our services have been kind of linking in with restart programs, the kind of welfare to work programs, who are supporting people who are unemployed or in kind of low income jobs to become gainfully employed. So linking in with workplaces or schemes where these routine and manual workers are is really important. Time of appointments, extend to earlier or later if possible. Absolutely agree, Gemma. Ruth, flexible appointments, absolutely, in terms of times, when and where we're delivering them, remote, face-to-face, using all the options we have available. Carol, that's really interesting. So potentially, and this is a generalization, but this is true for anyone who is a smoker and we're supporting. Of course, it's important to be aware of those environmental triggers, those high-risk situations, and of course, we might suggest that in some workplaces, absolutely, workplace triggers, workplace smoking on breaks and things like that may be a significant high-risk situation for some. So that's definitely an important consideration. Magda, I'll say it quietly, weekend clinics, but of course, if people are working all the way through the week, how are they going to access services? So that's definitely an important consideration. Robin, work breaks, social smoking can be challenging for this demographic, absolutely. Great, Ruth, you're currently working with a bus driver who loves the remote calls, that's awesome. and yeah, he quit after 40 years with a vape. So that's brilliant, some great success there, Ruth. Definitely, yeah. Oh, awesome, great result in supporting that individual to stop smoking. So yeah, some great suggestions there, everyone. I think got 3 here, and we're not going into loads of detail with these populations, but we've kind of identified, I think, all of these options here. So yeah, having that flexible approach, thinking about the different times and days in which we're delivering, thinking about the location, can we go into workplace, can we support online or remote, perhaps, targeted outreach engagement and engagement. So it's important to say that and this was a point raised on the Smoking Cessation and Health Conference. So in terms of these populations and other priority populations, they are not hard to engage, but they may be hard to reach. So it's important that we, use that targeted outreach to identify those populations and identify how best we can support them in the local areas, and then workplace triggers, as we've discussed. Just to kind of highlight, this isn't a new update, of course. This is a few years old now. However, we do have the Swap to Stop scheme that was introduced in 2023, and this may be an initiative, and I know that certainly in Norfolk that there is some kind of outreach and engagement specifically targeting using the Swap to Stop scheme to engage those who may find it more difficult to access our clinics and our services. So Swap to Stop was introduced in 2023, and the aim was to encourage 1 million smokers to swap cigarettes for vapes. They said that almost 1 in 5 smokers in England would be provided a vape starter kit alongside behavioural support. And just a bit of a case study, in Dorset, over 3,500 smokers successfully switched to vaping through the initiative, and a representative from that service joined the conference earlier this year, and they said that it was particularly useful because Dorset is a very kind of in places is quite a remote, isolated, kind of coastal and kind of rural area. So this was really great to kind of target resources in a specific way using the effective scheme of using Swap to Stop to provide those vapes to help people stop smoking who may not have been able to access clinics in other ways. I know, yeah, so similar support is being offered across different contracts as well with the Swap to Stop scheme. And Robin, you mentioned, yeah, digital offering could be helpful for Routine Emmanuel with a virtual coach outside of our usual business working hours. So absolutely, we'll talk about My Wellbeing Hub in a minute, because that could be a really great tool for these populations for sure. So that's just a little bit on Routine Emmanuel. Some really great ideas there in terms of supporting Routine Emmanuel populations, and just reminding everyone that we've got the Swap to Stop scheme available, and I know that there is work going on in many of our services on Swap to Stop. All right, so we are in the final half an hour of this session, everyone. So I am just going to skip slightly. So we were just going to do a group activity, kind of sharing success and challenges. However, we probably would have time to have discussion as a group, but not really feedback. However, this may just be something to think about after today's session. If anyone would like to share or receive any further support after today's session regarding any challenges in supporting service users on our services, and I'll mention it again, if there's anything on today's session that you thought might have been covered but hasn't been covered, or if there's any kind of further support you'd like from me and the Clinical Excellence and Service Development team, please do have a think, and feel free to send me an email, send me a message on Teams, send me an email, of course, for our external partners on the call today, or send me a call on Teams as well. So apologies we're not going through that group activity during the session. However, definitely some things to think about, and if there's anything I can support with, do let me know. We've already celebrated some of the success of our services in terms of the message that Nick, our divisional director, highlighted. So our services are consistently delivering quit rates above the national average. So, we are getting a lot of success, but if there's any support I can offer with any challenges, do let me know. Okay. So we're now going to have a look at innovation treatment. So this is going to be a bit of a quick fire, I think, if that's okay with everyone. Just this final section, really, where we're going to have a look at innovation in terms of treatments, NCSCT updates, action on smoking and health, and just a final bit on kind of read wellbeing. It's important to say that when I go through this section, everyone, I'm not kind of sharing anything that kind of leads directly to any kind of operational changes. These are we're just highlighting here some information about other treatments that are out there that it's just worth being aware of, other aspects of service delivery, some of which we are delivering, some of which we may develop in the future. So these are just things that we're thinking about, we're working on, and may become something that we are delivering in the future. Okay, so innovation in terms of treatment. So that there is a lot of research out there at the minute in terms of prescription-only medications, other novel nicotine treatments to help people stop smoking. I've just highlighted a few here just to get us thinking about some of the main ones and popular ones, and some really interesting research from the SCTRP update last year. So in terms of treatments, I just wanted to start with tobacco-free nicotine pouches. So I'm not sure if anyone's hearing about these nicotine pouches more in your clinics. However, usage has seemed to increase in the last 4 to 5 years, and there is kind of general kind of murmurs around nicotine pouches potential as a smokeless alternative tobacco. They are relatively similar in terms of how you use them to kind of lozenges or gum, where it's a bit of a kind of park method. You pop them to the side of your cheek, under your tongue, and allow the kind of nicotine to absorb. The main ingredients usually in nicotine pouches are nicotine, water, flavoring, sweeteners, and plant-based fibers. These aren't regulated by the MHRA, so these aren't approved stop smoking aids for stopping smoking. Some of these products can contain high concentrations of nicotine, really high concentrations of nicotine, and side effects can include hiccups, sore mouth, and upset stomach. And yet, not currently recommended as an aid to quitting within the UK. However, I think there is research going on to see if that may be an option moving forwards, of course, with the appropriate regulation. So that's just an interesting point around patches. In terms of breathing necklace or breathing whistle. So this isn't necessarily a kind of treatment, but something that is gaining popularity recently as a kind of coping mechanism. So it's gaining popularity, and as well as smoking cessation, it's also used in the management of anxiety and stress, also used to manage nicotine cravings. So usually these breathing necklaces have a kind of the kind of necklace around the neck, and they have a metal or kind of plastic kind of mouthpiece that's hollow, that you kind of breathe through. And essentially it is another kind of type of breathing technique. So it aims to activate the parasympathetic nervous system to help alleviate kind of anxiety and stress, and has also been found to help with withdrawal symptoms from stopping smoking as well. The action is very similar to doing a breathing technique such as a box breathing technique, or doing some grounding techniques. So some of you may be aware of the 5-4-3-2-1 grounding technique, where you take a few moments to sit still and identify 5 things you can see, 4 things you can touch, 3 things you can hear, 2 things you can smell, 1 thing that you can taste. So the kind of application is quite similar in terms of mindfulness techniques, breathing techniques. However, because you can see from the image, hopefully the image looks a little bit like a kind of cigarette shape. There is that kind of hand-to-mouth action that people associate with smoking that could also be helpful in helping people quit. So it's only come to my attention actually quite recently. but yeah, definitely worth being aware, as this is yeah, there's a lot of different options out there in terms of these products. Yeah, so worth being aware. And Gemma, great to have some insights. So you mentioned the way they draw the air through these breathing necklaces feels familiar, and you have a few participants using them. So great stuff. You know, as long as they're useful, don't really see any reason why they're not potentially useful. So that's really good. Thank you, Gemma. What I thought I'd add in here is a bit of a curveball next. So in terms of some research that was presented at an update last year. So they highlighted that there is some academical interest in diabetes or weight loss medications for smoking cessations, particularly medications that are glucagon-like peptide 1 agonists, which mimic hormones when we eat in our intestine and pancreas. And these medications inform our brain regarding hunger and the need to food, and also slows down gastric emptying. Initially for diabetes, recently also applied for weight loss. I've got a list of those medications there. However, there was a recent study last year into that was published last year into Wegovy or semaglutide, where they tested semaglutide against 7 other diabetes medications, and they found that patients on semaglutide were less likely to receive a diagnosis of treatment for tobacco use disorder within 3 months after treatment initiation. So there's suggestions that semaglutide may help with quitting. It's probably quite far off in terms of actual application in terms of using with our sort of smoking services and things like that, but this research is going on all the time. What I haven't included here is also increasing research around co-use of pharmacy-only, prescription-only medications and nicotine, so that's kind of growing. I mentioned before increasing data around medications that we already use for stopping smoking for use in e-cigarette cessation. So those are just some three treatments I wanted to highlight, but there's definitely some interesting research out there that hopefully I can share with you all as we move forwards. Cool. Let me know if you've got any questions on those. However, we'll move on to the next part. Yeah, great to have that feedback as well. Muchats, you mentioned lots of clients use straws, so these breathing necklaces will be helpful. Yeah, that's great. Oh yeah, really important before we have a look at innovations in terms of service design. What we've got here is just the NCSCT table, again from the commissioning, monitoring and delivery of smoking cessation services guidance. Here's a bit of a table in terms of what they don't currently recommend in terms of NCSCT recommendations. So the top kind of section includes where there's some evidence of effectiveness but not currently recommended. Interestingly, Alan Carr's Easy Ways seminars is actually recommended by NICE and is often part of kind of commissioning kind of guidance to include that as part of delivery. Of course, it's a kind of behavioural support that is at a bit of a conflict in terms of stop smoking aids, but that is approved by NICE. But interesting that NCSCT don't currently recommend it. Rapid smoking. I wonder if anyone's heard of rapid smoking. That's where if someone smokes much more cigarettes than they would usually do in a short space of time, to get to kind of force a negative feeling or a negative reaction to that smoking, so that then that negative reaction is that lasting kind of reminder of when they used to smoke, therefore with it being less pleasurable, potentially that may help people to quit. That's not currently something recommended by NCSCT, but there is some evidence behind it. And there are just some further kind of treatments there, including nicotine pouches that I've already mentioned, glucose, And at the bottom, so no effectiveness identified, not recommended in terms of hypnosis, acupuncture, acupressure, laser therapy, and electrostimulation. There is actually, I think it's CDC in America, they have actually approved transcranial stimulation for smoking cessation, which is really interesting. Not something for the UK, but yeah, interesting to be aware of these innovations anyway. Okay. Any questions on those before we move on to service design? Okie dokie. I'm mindful of time. Everyone will kind of go through the next part in as much detail as we can, but I will potentially just have to skim through a few of these. Of course, you will have the slides available after the session, so you may catch up if you would like to. It's important in terms of to start with in terms of innovation around service delivery, something that we've developed as a company. So some of you may be aware, certainly if you're in Norfolk, you'll definitely be aware, but over the last kind of year or so, 18 months, I think really, we've developed our own online platform for supporting people to make behavior changes, called My Wellbeing Hub, which is an app that can be accessed on kind of mobiles and tablet and computer devices. That's essentially a kind of 12-week self-service Be Tobacco Free program. So the first program that is active on My Wellbeing Hub is the Be Tobacco Free program, a 12-week self-service program. It was actually a commissioner requirement from Norfolk, so that at the start of the second year, an online kind of self-service provision was created, so that kind of pushed this My Wellbeing Hub. But this is something that we've been thinking about for a little while, and the hub offers kind of daily activities and behavior change methodology to help participants to learn how to live tobacco free and develop healthy lifestyle habits to quit tobacco for good. And it went live at the beginning of April, and I think in the last week or so the first few kind of referrals have come through, which is great. It would be great to see how those referrals go when they start. It's important to say that the program utilizing the My Wellbeing Hub isn't just about the content on the My Wellbeing Hub. It's important to say that there is coaching interventions scheduled at various stages along the program, because we identified the need for coach support in terms of participant safety, but also the obviously specific and particular support that we can offer to participants, to tailor support, to tailor advice, to offer behaviour change support, to offer kind of your experience to support participants. So it's hopefully a bit of kind of best of both worlds, really, where we're kind of moving into the digital world, but still retaining the important coach function. Okay, so the hub is created using evidence-based guidance. The program includes interactive videos that guide participants through planning to quitting and sustaining a tobacco-free future. There's different badges for achievements, SMART goal setting, progress tracking, and rewards to enhance motivation and engagement. So yeah, there's a lot of kind of gamification on this hub to maintain that engagement throughout the course of the program. The program, as I mentioned, comes with check-ins to have those treatment discussions and provide further support where needed. There's a text messaging platform between the app and the program support team, where they will kind of delegate that the kind of dialogue or the messages to the appropriate person within the service when needed. There's also access to a kind of general well-being quiz, so not just about smoking, but general well-being, and a kind of library of useful advice and articles that participants can access on the service. And there's additional support through signposting pages as well. So and there's also built into this hub where kind of reasonable adjustments are required, where larger text is required and other needs, there's a widget that enables kind of more people to be able to access this service, this platform. So in terms of My Wellbeing Hub, we've of course created that Be Tobacco Free program, and the next stages are integrating and adding further programs and platforms to this platform, to this digital wellbeing hub. And the next steps are adding Lose Weight, Drink Less, and Move More onto the program. And we're currently at the discovery kind of phase of the service delivery of these kind of work streams of these programs. And next week and the week after, we do have some discovery sessions where we would like as much co-member involvement as possible on these sessions to discuss what, if you've got any expertise or would like to share some information around kind of a Lose Weight online program, Drink Less program, Move More physical activity program on this My Wellbeing Hub. We'd really like your kind of feedback and your kind of pointers in terms of what you feel would be important to include when these are added to the platform. So I've added the dates of the discovery sessions there. On Viva Engage in our clinical excellence channel, there is also this link to access the Microsoft Forums if you would like to attend any of these discovery sessions, or if you'd like to attend any of these discovery sessions to talk about adding these services onto My Wellbeing Hub, please do reach out to me and I'll be happy to add you to the discovery sessions as well. Okay, so that's what's to come. The aim is to have these programs on My Wellbeing Hub by the end of the year. Still, these are integrating into the programs that we already deliver, so there will be key kind of coach involvement with interventions with all of these services, but definitely an interesting move forwards into the digital world where lots of services are. Maybe interesting to learn that in Medway in Kent, they're currently developing and piloting a specific AI stop smoking app with, I think, limited or almost no kind of coach involvement. I'm not sure how I feel about that. I think coach involvement is crucial to these programs and the success of participants accessing these programs. So yeah, that's definitely something that we're not looking into ourselves just yet. The coach involvement is still absolutely crucial. All right. So that's My Wellbeing Hub, everyone. Another service delivery that we are also developing is remote groups. So on pretty much all of our programs, we do deliver or have the provision for face-to-face groups. However, on few of our services to only a very limited sense, we've adapted that group session content to remote. However, there's been a specific requirement, particularly in Stoke and Leeds, for remote groups, and we are seeing this coming up in kind of bid opportunities and things like that. So we're currently at the kind of product scoping stage for remote groups, where I've sent this proposal off to the operations team, and I think next week or in the next couple of weeks we're hoping to have a few product scoping sessions with ops managers to see what they would like to see in terms of these remote groups. So that's something that we are delivering. We know that group delivery is currently the most effective stop smoking service delivery setting. Remote may make it a little bit easier for some people to access the peer support, because I know that it has been challenging to get face-to-face groups off the ground in some places. Of course, with this particular service, there is a need to balance the number of people attending these sessions with still a requirement for one-to-one treatment discussion. So that's a bit of a balance that we'll work on, and we'll scope all of that out in the coming weeks. Bit of a quick fire now, everyone, because we are coming towards the end. So in terms of innovation, so cut down to stop. Now, cut down to stop isn't new by any sense of the imagination. However, I think it is starting to kind of grow, not just as a kind of work stream for people on our services who aren't ready to fully commit straight away, but as a legitimate and not just treated as a kind of second or third line approach to stopping smoking. You know, as smoking prevalency reduces, cut down to stop may become more of a significant, more of a prominent way of supporting people to stop smoking, not abruptly, but you know, within the recommendation of 6 weeks, which is the recommendation from NICE. Of course, cut down to stop, we do already have it on some of our programs, and again, as I say, it is you know, in lots of cases, not always, but just the program that participants kind of move to if they're not able to commit to that abrupt quit. So I think there's definitely going to be kind of more thought into using cut down to stop as a kind of legitimate way to help people stop smoking completely. And there is evidence already out there that kind of treatment alongside cut down to stop can be effective, including using patches and e-cigarettes, but making sure that if someone is using treatment to help with their cut down, the treatment is sufficient, has sufficient NRT, because we do nicotine, because we do find that if someone uses treatment to cut down, however, they don't use sufficient nicotine, that may lead to compensatory smoking, so smoking more than they were previously. So running out a little bit of time there, but cut down to stop may be something that we develop a little bit more moving forwards. And I've just added here the kind of harm reduction strategies for cutting down to stop there, that many of us will already be familiar with. It will be in the slides. Okie dokie. So smokeless tobacco. So yeah, just very quickly on smokeless tobacco. We are starting to see referrals into some of our services around smokeless tobacco users. I know, I think, Veronica, you came to me kind of a few weeks ago, maybe a kind of month ago, with, I think, potentially the first smokeless tobacco referral for Kingston, Westminster and Chelsea, where your service does have in the service spec that we can support smokeless tobacco users. So potentially as smoking rates reduce, smokeless tobacco rates are still quite low in the UK, around kind of 1% prevalency in adults at the moment, but there may be more to come from supporting people using smokeless tobacco to stop. In brief, the kind of guidance is very similar to stopping smoking in terms of the treatments that could be used, although kind of sufficient guidance is kind of lacking in this area, and kind of funding as well, being funded for smoke tobacco and not smokeless tobacco. But there is evidence that NRT and even varenicline can increase quit rates of smokeless tobacco. So this is something that will develop, and it's definitely on my mind to create a bit of a program around as and when more need for this comes to our services. And next we've got e-cigarette cessation. Okay, so yeah, evidence is emerging on what works for vape cessation. There is actually a vape cessation pilot for young people in Alderhay up in Liverpool to try and address youth vaping in that area. The advice from NCSCT is very much using the kind of brief advice framework. So asking clients about their reasons for wanting to stop vaping, provide accurate information, reassurance, and clarify any misinformation. And of course, assess risk of relapse. Important that people don't return back to tobacco. And if people still want to come off the vapes, offer tailored support to clients who want to stop vaping. Again, evidence is lacking in this area. There is potentially what has been suggested as kind of the common sense approach, which is gradually reducing the dose of nicotine in e-cigarette liquid over the course of a quit attempt. So that definitely is something that you may already be doing in our services, and it is definitely recommended as long as that doesn't lead to an increased risk of relapse. There are some thoughts, some research that I've already mentioned in terms of using prescription-only medications, even NRT, coming off vapes using NRT. So this is an area that we want to develop in addition to kind of youth vaping education. So this is something that we'll definitely kind of make sure we have an eye on over the next weeks and months. We are at 1 o'clock, everyone. It's probably going to be 5 or 10 minutes for me to conclude the session. Of course, if anyone does need to leave, as it is 1 o'clock, that's absolutely fine. Completely understand, of course, you'll be able to catch up on the recording. But as I am recording this session, I think it's good for me to go through the rest of the slides. So apologies for running a bit over, but I'll just go for another 5 or 10 minutes if that's okay. Just some updates in terms of professional practice, everyone, to clinical guidance. So the most recent update to the NG 209, tobacco preventing uptake, promoting quitting and treating dependence guidance. Back in February, the most recent update was new and revised recommendations regarding stop smoking interventions with cytosine added to the guidelines. So that was the most recent update in February 2025. And of course, we'll continue to keep abreast of any changes to the guidelines in the coming weeks and months. In terms of NCSET developments, everyone, so there is last year, as I've kind of referred to a few times during this session, there is a new local stop smoking services and support commissioning, delivery and monitoring guidance. So I've used this, a few times already to inform this session so far. This is a new bit of guidance from NCSET covering, their latest recommendations around supporting people to stop smoking, some innovations that we've just mentioned there, and also monitoring performance of stop smoking services. So definitely an interesting guidance to have a look at if anyone would like to in your own time. Let me know if you can't find it. I'll be happy to forward a copy to anyone if you would like me to. But in terms of other NCSET updates, they, of course, in terms of training, recently added the National Smoke-Free Pregnancy Incentive Scheme e-learning module. I think that was last year. Updated guidance in terms of Varenicline. There's a new combination nicotine replacement therapy update briefing and the commissioning, delivery and monitoring guidance. So NCSET are always kind of updating their training and updating their protocols. So as and when there are kind of significant events, I will do my updates. I will do my best to share those updates with you all as and when they come. Okay. In terms of action on smoking and health, so just very quickly on action on smoking and health, I would definitely recommend Action on Smoking and Health that you sign up to their email newsletters. So daily they provide an email newsletters with the latest in terms of research around tobacco, treating tobacco, smoking cessation and other relevant information relating to smoking cessation as well. They regularly update kind of new reports, research, fact sheets and briefings. So I've listed a few of those here. I won't kind of list all of them, but I would definitely recommend, if it's not already, adding Action on Smoking and Health to your kind of daily adding yourself to the daily mailing list. And in terms of kind of communications moving forwards, I would like to, potentially bring together some of this information a little bit better and potentially provide kind of 2 monthly bulletins of kind of the latest information from ASH. So that may be something that we focus on a little bit in the future. Just a little note on ASH in terms of legislation that we discussed earlier. They are a great promoter of the tobacco and vapes bill, but they're also doing a lot in the background in terms of trying to get profits from tobacco companies and use those products for tobacco control funding, smoking cessation services and things like that. So that they do a lot of kind of lobbying for stop smoking services as well. Final few points, everyone. So just a reminder regarding clinical incident reporting. So of course, there's a really important process on our services for the kind of safety and the support that we're offering for our participants. I won't go through this in detail today, but of course, really just important to kind of be aware of our clinical incident reporting procedure. Do let me know if anyone's got any questions. Of course, what counts as a clinical incident is potentially adverse reactions to treatment. So anything that goes beyond a kind of routine side effect that may be expected, and a clinical incident, so any act or omission by Reed Wellbeing that leads to harm in some way. Usually we average a couple of clinical incidents a month. Potentially that's really great news, but I would really encourage you to just be familiar again with the clinical incident reporting procedure, and do reach out to me if you've got any questions. It's a no judgment kind of system. We obviously really appreciate when we do get incident reporting coming through. Shows that you are following the guidelines, and you are ensuring that the best quality of support is offered to your participants. And of course, if there's any kind of learning or any support needed, then of course once those incidents are reported, then we can support you. Okay. Final few things. So yellow card reporting system, always worth just being familiar with yellow card reporting system whenever we're aware of side effects or adverse reactions in terms of treatments or anything to do with our clinics. Really important that they're recorded on the yellow card reporting system with MHRA. In terms of training, so just a quick one, that this would mainly be for kind of line managers really, but I've updated my kind of internal training schedule